um, that, you're also going to look at the chart. What information can you get from the chart? You can get the lab results, any diagnostic test results. Maybe you're going to find the admission history and physical exam by the physician. Then you need to interpret and validate the data. Well, what does that mean? Well, you need to look at the data and say, well, what does this data mean? That's the interpretation. And then validation. Okay, the patient told me this. Is that valid? So, say the patient says, I feel like I'm running a fever. I feel hot. And you go and look at the vital signs, and yeah, it has temperatures, 102. Okay, that's you validated the information that you gathered from the patient. When you gather it, you synthesize what's relevant. You're going to use prior clinical experiences to say, okay, well, when I've seen this before, this. You're going to use critical thinking, standards and attitudes, and also professional standards of practice. So this is going to direct your assessment in a more meaningful and purposeful way. So the two steps are, again, collect the information from both primary and secondary sources, and then interpret and validate the information. So paramount to being able to complete assessment is developing a relationship with your patient. Your patient's not going to give you any information if they don't trust you and they don't feel like you're important. So we have the patient information you get from their interview, observations of the patients that you make, and your actual physical examination. Family members may report, or you may get, they may respond to questions, the medical record, the history labs, x-rays, consults, literature. So any evidence about disease conditions, assessment techniques, and standards. Literature is great when you want to keep up to date. So, and by literature, it's not just reading a journal, although that is helpful. Sometimes the CDC comes out with literature. Sometimes you'll find an article in a newspaper that maybe is really interesting, but they've cited their sources, so then you can actually go and look it up. You want to make sure when you're with your patient, you're doing quality time. Now you may be like, well, wait a minute, we have so many patients. How am I going to do quality time? It's just not possible. It is possible, guys, okay? What you need to do is, even if you're just taking a few minutes, so even when you're doing your hourly rounding and you're stepping in and you're checking in on your patient, and I'm going to go in and I'm going to see Veronica. And I'm going to say, hi, Veronica, just checking in to see if you need anything. How are you doing? Can I get you anything? Um, Otherwise, if not, then I'll be back in another hour to check in on you again. That helps develop that relationship with the patient. They know that you're going to be around. They know when you're coming back, and it makes them feel important to you. When you have that nurse-patient relationship, it allows you to get to know the patient as a person. Not just the patient in room 203. Oh, that's Veronica. I love that patient. She's great. She's nice. She's so sick, though, or whatever. Sorry, Veronica, I'm picking on you today. I'll pick on somebody else tomorrow or next class. And it occurs in any time of your shift. Anytime you have interaction with the patient, you're developing that relationship. It helps connect with the patient so that you can actually get the information you need to build a valid database, whatever. So, research shows that hearing accounts of patients' health and illness experiences, watching them, coming to understand how they typically respond, develops a type of knowing that helps you develop that good clinical judgment because you can recognize things. Rounding, like I said, helps increase the likelihood that you will gain information so you can identify and communicate health problems accurately and effectively. So we have three types of health assessment, okay? We have the patient-centered interview, which is pretty much just what it says. It is, you're talking to the patient, it's an interview centered around them. What does that mean, though? Well, it's like taking the nursing history, and we'll get more into the parts of the nursing history in a little bit. So You're asking about their health history, medications they're on, allergies, social history, functional history, all of that information. You're going to do a physical exam. That's your head to toe examination, or it might be focused. So you may be only looking at specific areas of the body or specific systems. And then you do your periodic assessments. That's when you're doing rounding. You're going in to assess to see how your patient's doing. You're giving care. You're doing wound care. You're going to assess that wound while you're in there. That's part of the periodic assessment. So you also need to think about what you need to assess in a specific situation or with a specific patient. If you're in the emergency room and someone comes in with chest pain, what are the things that I need to look at? Well, you're going to look at your patient. Are they diaphoretic? Are they grasping their chest? Are they short of breath? Do they seem like they're fine? A cue, you get cues from your patient, and the cue is information you obtain through your senses. So your sense of smell, there are a lot of smells in the nursing world. If you gag at smells, you may have an issue. Sight, you see what's going on with your patient. Hearing, you hear what your patient says. Taste, sometimes you can even taste things, or taste a smell. Really gross, I know. And touch. Touch is very important. That's part of your physical exam. Inference is your interpretation of the cues. So you get a cue, and how do you interpret that information? So you go in to see your patient and they're diaphoretic and they're almost panting, they're breathing rapidly. Well, you can infer that they may be running a fever, they may be having chest pain, something like that. And there are you also have your comprehensive assessment. And that's where you go from a general overall assessment and then you move to the more specific, so the body systems. You can use a structured database format or problem oriented. So what's the problem? What am I looking at? You're going to cluster clues to make inferences and then identify the patterns and your potential areas. So what kind of data are you going to get? Well, there's subjective data, which is the patient's verbal description of their problems. Oh, I feel like I'm running a fever. To the objective data where you're actually getting their temperature and oh my gosh, the patient's temp is 39.3 Celsius. So I want you guys to go ahead and type in the chat. Everybody let me know. We're going to go over subjective data. What do you think you might find subjectively with your patients? Mm-hmm. That's all right, Alicia. Symptoms, how the patient's feeling, my blood sugar. Jeanette, that's a good one. They're going to tell you their blood sugar is high. So then what are you going to do to get objective data to validate that? Glucose check, gastric cramps, check their blood sugar. Good. So then you guys got a great grasp of the objective data. Oh, Angelica, I like that one. Feel like my heart is racing. So what, that's a good subjective. So what are you going to do objectively to verify what the patient says? Check their pulse. EKG, absolutely. Sade, I think you haven't muted yourself. I'm hearing some background and it looks like it might be from you. Thank you. Right. So if I come in and say I have a headache, that's subjective. What objective data do you think might verify that I have a headache? Temperature. Good, Natalie. Blood pressure. Absolutely. Pulse. Yep. So you guys are thinking about the physical objective data. What other objective data sources might you look at that would validate that I have a headache? Right, Natalie? What specifically might you look for in the medical record? Medications, white blood cells? What other tests might help? Lear, the me explaining they have a headache is pretty much subjective. Previous history, Natalie, maybe I have a history of migraines. What else in the what other diagnostic data? Yes. That's what I was getting at. Imaging, radiology. So don't forget to look CT for sure. Don't forget to look at all of those. Those are all objective because MRI, very good. Those are all sources that you guys will use to validate what the patient's telling you. So if we have your patient, we're gonna say this patient with chest pain. They came in with chest pain. You've done your assessment. You've checked. Okay, they say their pain's this out of this. Their cardiac enzymes are showing that they may be having a heart attack, and they're going to the cath lab. So now they're going to the floor after the cath. They had some stents placed. What is going to validate for the nurse who's taking the patient that this patient had chest pain or has a cardiac issue? Labs, the EKG, heart monitoring, Mercedes, yep. It may show on there. Echocardiogram, Bell, you guys are getting warmer. Other providers, ambulance report. Yes, Veronica, thank you for the other providers. Natalie, very good with the ambulance report. CTA. How about the cath lab report? That'll probably either under procedures, may even be under imaging. So the reason I wanted to do this with you guys is because I want you to be aware of how broad and wide your database is when you're gathering information on a patient. It's not just what the patient tells you, which is subjective, and it's not just the objective data that you see. It's all the information encompassed within their chart and other providers. So we talked about sources of data. We talked about the patient, the family, the healthcare team. You talked about other doctors, talk about consults, medical records, other records in scientific literature. The other thing that's a source of data is your experience. You may have taken care of a patient who's had chest pain and a cardiac cath before. So in your experience, you're going to have certain things that you already know, and it's already been validated because you've done this before. So don't discount your experience and be like, oh, I don't know. Yes, you do. Yes, you do. You know things more than you think. And eventually, as you get further on, you're going to feel way more comfortable using your own experience. Patient-centered interviewing. Interviewing patients is very, very tricky. Sometimes they don't want to give you information. Sometimes they don't understand what you say. So you have to be very careful in how you're interviewing them and drawing out information. So the patient-centered interview is relationship-based and it's kind of an organized conversation because you have an idea what information that you want. Your primary objective during the initial history is to get details about a patient's concern, explore what expectations they have, and to display a genuine interest in a partnership with the patient. So a lot of times when I was practicing as a nurse practitioner, my medical assistant would go in and say, "Oh, Mr. Jones, what brings you in today?" And Mr. Jones would tell her one thing. And then I'd go in the room and Mr. Jones is telling me something completely different. Or the patient calls and schedules an appointment for an annual wellness exam. And the MA says, "Oh, I see you're here for your annual wellness." "Oh, yeah. Do you have any concerns?" "No, no, I feel pretty good." And then I, as the provider, go in the room and the patient's like, "Well, I have this wart on my foot, or I have this pain in my lower back every morning." So it does make a difference, and it is very difficult to be able to get these things out of the patient. So motivational interviewing is a process that helps to address the patient's ambivalence to medically indicated behavior. So, "Oh, I don't know if I want to take this medication." It helps change and support the patient in making healthcare decisions. So by switching to motivational interviewing, what you're doing is you're blah, blah, motivating the patient to want to change. It's a very tricky technique, and honestly, I use it and I don't even know I'm using it. So it's interesting how you will eventually get there. Well, don't you think you would feel so much better if you started taking your blood pressure medication? You told me you've been getting headaches. Those headaches may go away. I'm providing the patient with the motivation and the rationale as to why they should make the change. When you're communicating, it needs to be effective, because if it's not effective, it's not going to do any good and you just wasted your breath. You need to use the 4 C's. That's courtesy, comfort, connection, and confirmation. Yes, Hayes, absolutely use psychology on a patient. 100%. You need to use psychology on the patient. It was interesting because I was working when I was practicing, we had behavioral health services, and I had a mutual patient who was with behavioral health. And I was actually talking to him about how we can get her to make changes that she needed and how to work with her. And I was talking to him about discussions I had with the patient. And he actually told me I was using motivational interviewing and I didn't even know it. So it's courtesy, comfort, connection, and confirmation. So courtesy, greet the patient. "Hello, Mr. Jones." Ask how they want to be addressed. "Would you like me to call you Mr. Jones or would you like me to call you Bill?" Sometimes I would just say, "Hi, Mr. Jones. I'm Deirdre. I'm going to be your nurse today." And then Mr. Jones may say, "Oh, call me Bill." And that's okay. Yes, Kristen, confirmation. Introduce yourself, explain your role. Common courtesy that you would do when you meet anybody. You're meeting your patient. If you have your patient for the second day and you're going in and it's your next day and you go into the room, "Hi, Mr. Jones, it's Deirdre. I'm going to be your nurse again today. It's so nice to see you. How are you feeling?" Comfort. So make sure you do that before you interview, make sure you make them comfortable. If they're having pain, give them pain medications, maintain the patient's privacy, make sure the room is comfortable, the lighting's good, and it's quiet and free of interruptions. You want to make sure that if the patient feels comfortable physically, they may feel emotionally more comfortable to reveal things to you. Connection. Make a good first impression. You want to make sure the patient feels that you're a competent nurse. If they don't feel that you're competent, they may have issues. Establish eye contact. You guys can't see it because I've got my screen up, but I am literally looking at my video camera as I'm talking. Yes, Veronica, trust. You want the patient to trust you. I'm literally sitting here looking at my camera, pretending like I'm looking at you guys while I'm doing this. Sit at the level of the patient as possible so that you both are at eye level. And then listen and be attentive. Make eye contact. Make sure you engage. Even if you're saying something as simple as, that can make the patient go, "Oh, she's really listening to me." And then confirmation. Confirm what you heard. Ask the patient to summarize it. Be open to further clarification and discussion. You may even say to yourself, "Oh, I'm sorry, Mr. Jones, I'm not sure I understand. Could you?" So I heard you say this. Is that correct? So it's confirming what you were just told. You want to make sure you review your medical record before you go in to see the patient. Some patients are very cranky, and if you go in and ask them a question they've already been asked 30 times by the admitting physician and two consultants, they're going to be pissed. They always are. Always happens. Well, I told them. So make sure you review your medical record before you go in. Create an orientation and set an agenda. Introduce yourself, your position, the purpose of the interview. Assure them that their information is kept confidential. Ask for the patient to list their concerns and problems. Now, you may get a short initial list, and then as you develop the relationship, it may end up growing later on. So that's the orientation phase. Next, you're going to go into what's called the working phase, where you're going to get in the meat. You're going to start with open-ended questions. You're going to have the patient explain or describe, "I'm having abdominal pain." "Okay, Mr. Jones, tell me a little bit more about your pain. Can you describe it for me? Where exactly in your abdomen is located? How did it start?" But just asking them to describe it may get them talking a little bit more, and then you can pull out stuff. Encourage your patient and try your best not to rush them. Now, I know that's easier said than done when you have 6 patients to take care of. However, do your best to make them not think you're rushing them. So sometimes you have to actually make them feel like, sorry. "Oh, I'm sorry, Mrs. Smith, but I really need to go see my next patient. When I come back in the hour, can we resume our conversation?" And then maybe make Mrs. Smith the last patient on your next hourly rounds. And then you have your termination phase. You summarize the discussion. "Okay, Mr. Jones, you told me you're having abdominal pain. It started 3 weeks ago. The pain's a 4 out of 10, and you call it a dull aching with occasional sharp stabbing, and it's constant. Is that accurate?" Then so you summarize and you check for accuracy, and then give clues the interview is coming to an end. So summarizing is a good way to do that. Let me sum up our conversation. Is that what I understand? "Okay, Mr. Jones, well, I'm going to go call your physician now and see what we can do to help you." So the three phases of interviewing is orientation, where you introduce yourself and you get basic information. The working phase, where you do the open-ended questions and have the patient explain. And then termination, where you summarize your discussion and then cue in the patient that you're ending the interview. Some of your interview techniques. You're going to be using observation of nonverbal communication. You're going to look at a patient's body language. Are they making eye contact? Now, eye contact is tricky though, guys, because in certain cultures, making eye contact is considered rude. Or in certain cultures, excuse me, you may have a female patient where the culture, the female is more subservient. So the husband might do all the talking for her and she's looking down and not making eye contact. So be aware of that. You're also going to look at their tone of or listen, not look to their tone of voice. Their appearance. Are they showered? Have they bathed recently? What do their clothes look like? Also in appearance, you could include body odor. Whew. Had some patients that I literally had a hard time sitting in the room with because of their body odor. How they interact with their environment. And then is all that nonverbal stuff that you're seeing, does it jive with what the patient's telling you? Is it really what the patient's saying? Open-ended questions. Huge, guys. Practice your open-ended questions. Practice on each other, practice on your family members. See, this is a big one. You need the open-ended questions, not yes, no, not one-word answers. You need to be able to draw information out. This takes time and practice. It helps the patient describe their actual situation. So tell me more about, okay? Tell me how you're feeling and show that you want to hear the patient's thoughts or feelings. So you may say, Mr. Jones, how are you feeling today? Pretty open-ended question. However, he may just say, I'm fine. Well, that didn't give you much information. Mr. Jones, what's changed from yesterday to today? That might give you more information about how he's truly feeling. Is he feeling better? You might do some leading questions, which is exactly what that was. They can be risky because they can limit the information you get. And the patient might actually, yes. No, we have not, Veronica. Not a problem. Actually, that works great, guys. So honestly, if you have something in the middle while I'm lecturing, don't hesitate to pop your question up. Okay? Because I want to be able to answer it in the moment when I'm thinking about it, other than going back and going, what did I say 5 minutes ago? Because my lectures, while I have a guideline, they're not always the same. So back to leading questions. The patient might also just give you what they want, what they think you want. So the patient wants to go home from the hospital. And you're like, how are you feeling today? Much better. Are you having any pain? Nope, no pain. But they're grimacing and not moving in bed. They don't jive together. So a leading question could be something like, it seems to me that this is bothering you quite a bit. Is that true? You're leading the patient to tell you, yeah, yeah, oh yeah. You think it's bothering me, so I'm going to tell you it's bothering me just to make you feel better. Not really the best way to go about things. Then you have back channeling. So those are active listening prompts, and they reinforce your interest in what the patient is saying. So things like, "Oh, go on. All right. Uh-huh. Interesting. Okay." Those are all active listening prompts. They tell the patient that you're still there, you're still listening. And then you have your direct close-ended questions. They focus on symptoms that the patient identifies and limits your answer to one or two words. Yes, no. How many bowel movements have you had today? 5. It doesn't give you much information. So, okay, well, tell me what your bowel movements look like. Describe them to me. That's a better open-ended question. Nursing health history. Oh my God, guys, this is so huge. This is the one thing that you really need to get nitty gritty into. It is very much a key component of your assessment. You also have to take into account like cultural considerations. So a good assessor listens in order to try and refine or broaden questions as needed so that you can actually assess the needs. So you're really listening to the patient and cueing in on, oh, I need more information on, okay? You need to be self-aware so that you're not making cultural stereotypes and reflective. And then kind of have a knowledge of a patient's core cultural issues. So you may meet a patient of a different culture, religion, whatever, and you're not familiar with that. It's okay to ask them. In fact, patients very much enjoy it when you ask them to clarify rather than you trying to falter around. You want to be respectful about that, but you can do that. For instance, when I was working on a telemetry unit, we had a patient come in and I was doing her admission assessment. And one of the questions we always have to ask is a religious preference, just to verify, because sometimes they didn't get it downstairs. So I asked her religious preference, and she told me she's Wiccan. Well, okay, the reason we ask that is so that we can also see if they want, a priest or rabbi or whatever to come in and, see them. I don't know that much about Wicca. I mean, I know the basics. I know the basis of the Salem witch trials was on Wicca, those kinds of things. So I actually said to her, "Okay, I'm sorry. I'm not very familiar with the Wiccan religion, But can you tell me a little bit more about it? Do you need to have someone come in, like, I don't know, a witch, wizard, I'm not sure what the terms are, to do a blessing or anything for you? And she laughed and chuckled and gave me a nice smile and said, "No, I'm okay. Thank you though." So I felt good in that I admitted I didn't know much, but I didn't downplay. Oh, you're Wiccan. Okay. I asked her the same exact questions that I would ask. See, priestess, that's the thing, Hayes. I wasn't really into that. So, I know that witchcraft is not Wiccan. However, it has been confused Salem witch trials. So, and other people who practiced Wicca were thought to be witches. So that's where I read that. My daughter's pagan, and I have a friend who's pagan. So, anyways, point being though, it's okay to ask the patient to clarify um, what. Yeah, it's all interesting. I'm kind of delving into it a little bit. But anyway, so it is important to clarify, even if it's a cultural, religious, whatever belief that you have. You have a patient who's transgender. You don't really need to ask them their pronouns. If you have a patient that's transgender and they come in and say they're female, you call the patient a she, even if you know that is a man as a woman. She, that's the preferred pronoun. If you feel you need to ask, you can ask them, what is your preferred pronoun? Okay. But you don't, it based on their appearance, you can probably assume, but you know what they say about assuming? It makes an ass out of you and me. Don't impose your own attitudes and beliefs. So make sure you put your own attitudes and beliefs in a little box in yourself and leave those there, completely unbiased. And it's not easy to do, and there are times where I disagree with the patient, but they have that right to believe, even if they're misinformed. If I've tried to educate them and they still are firm in their beliefs, it is what it is, and you can't change them. And then of course, don't stereotype people. All right, guys, here's your quick quiz. I told you I was putting more in there. So your patient is admitted to the hospital with shortness of breath. And as the nurse assesses the patient, what part of the nursing process what is the nurse using? Is it evaluation A, B, data collection, C, problem identification, or D, testing a hypothesis? Hmm. Interesting. A lot of you are choosing A. So remember the nursing process mnemonic. It's ADPI. So it's assessment, diagnosis, planning, implementation, and evaluation. So you're admitted and you're assessing the patient. That's where you're collecting your data. So always remember that assessment is data collection. Now I did see a C in problem identification, and yes, Hayes, evaluation is the end. And honestly, I can completely see why you would choose C, because you're going to identify the problem, but that's more of the diagnosis point. So first you got to collect your data. That's assessment. All right, components of your health history. So there's a lot of components to make a health history, guys. Some of it will already be gathered for you by different people. So for instance, biographical information in the demographics, address, phone number, email, religious information, that may already be gathered for you. So you don't really need that. Patient expectations, you definitely want to know what the patient expects. Chief complaint or their reason for seeking health care. That's, why are you here? Kind of. Make sure you put the patient's response in quotes. So if the patient says, I'm having chest pain, and you're documenting, I'm having chest pain, make sure, I just did air quotes and you guys can't even see me. Make sure that you use those quotations marks. In fact, quote your patient as much as possible, word for word, put it in quotes. That actually is big at covering your butt. Clarify any perceptions. Provide education, counseling. You might do any referrals to any resources. What does the patient expect to happen while they're there? What expectations have been met at the end? And if not, how can we make it better? Present illness and health concerns kind of goes with the chief complaint, but now you're going to delve a little bit. Well, when did this start? How severe is it? Describe it to me, or the quality, which is sharp, aching, dull, stabbing, shooting. What makes it worse? What makes it better? You're going to use a thing called PQRST. There's another slide further on where I talk about, in fact, it's the next slide, that'll give you a good mnemonic in order to help you determine what you're looking for. And any other symptoms that might be coming along, any concomitant symptoms that are coming along there. Your health history gives you information about their past history. Have they been hospitalized? Have they had a procedure? What medications are they using? Not just prescription medications, but any over-the-counter or herbal supplements. Social history like alcohol, tobacco, caffeine use, drug use, sleeping patterns, exercise, nutrition, any family history, any recent losses, any religious influences. Jehovah's Witnesses is one. They won't take blood and they won't take transplants. Relationships, allergies, habits and lifestyle patterns. Do they get up and move it, move it? Family history, you're looking about immediate blood relatives. So that helps them determine the genetic risk. If they say, well, my stepdad doesn't count. Stepdad isn't blood related, so they do not share DNA. You may get an environmental history. What is their home environment like? Do they have a home? What is the workplace like? Are they exposed to anything in the workplace? Pollutants and such. Psychosocial, do they have a support system? Are they married? Do they have a significant other? Children? Any other family? Spiritual health, their beliefs about life, source of guidance in acting on beliefs, the relationship with family in exercising their faith. Also rituals and religious practices that they use to express their spirituality. Maybe they're Catholic and every Wednesday they go to Mass in the evening and say the rosary. Then the last one is the review of systems. This is a very systematic approach, guys, where you collect subjective information from the patient about presence or absence of health-related issues in each body system. During the review of systems, you're going to ask about normal function of each body system and any noted changes. So, for instance, I'm going to throw out here GI. So you may say to your patient, okay, are you having any abdominal pain? They're saying yes. Okay, so tell me about the pain. Have you had any change in bowel habits? Are you having any constipation, diarrhea? How often do you have a bowel movement? What is it normally like? When we do the GI tract, we'll actually get into the Bristol stool scale, and you guys will be like, what? It is actually a picture scale, kind of like the Faces Pain scale, where people can identify what their consistency of their poop is, and it will let you know, are they constipated, diarrhea, or within the normal range. So like I said, this is Poltkarts. Your book calls it, uses PQRST, very similar. Okay. So this is what I learned actually when I was in NP school, and it really is a very good one for assessing in general. And I thought, I wish I'd have had this when I was in nursing school. So, previous occurrence, have you ever had this before? If you have, when, and was there anything you did then that helped make it better? Onset, when did it start? How long have you had it? Location, if it's applicable, you may not have a location depending on what you're assessing. Duration, how long does it last? Is it constant? Is it intermittent? Characteristics, describe how you feel. The pain is stabbing, shooting, dull, aching. That's quality in the PQRST. Aggravating, is there anything? Oh, I flip-flopped those. Aggravating, no, I did get that. No, I messed that one up. I need to fix that. Sorry, guys. Aggravating factors. Is there anything that makes it worse? Okay. Anything that aggravates it, making it worse. Relieving factors. Is there anything that makes it better? Anything you've done that made it feel better? Timing. Is it happening at a particular time of day? Heartburn is a big one. Depending on the time of day, depends on where you're going to go with that. And it's very, very interesting where that happens. And we'll get into that later. And then severity. You know, if you're looking at 0 to 10 scale, is it so bad that it prevents you from doing things if you're not looking at pain and that kind of thing? Okay. So we're going to do observation, verbal, nonverbal. That helps add depth to your database. And it'll direct you to get any additional information. You want to get their level of function. Then you're going to look at diagnostic and lab data, results of any tests that they've had. Assess involves continuous interpretation. You're always. Honestly, Veronica, there isn't a particular test question about PQRST or pulled cards. I teach it to you basically because it is a very, very good health assessment technique. It gives you a systematic, organized way to assess a health issue. Interpretation, that's where you determine the presence of abnormal findings and recognize what else you need to clarify it and begin to identify patient health problems. Patterns will reveal data clusters. So that is a set of signs and symptoms that you get grouped together in a logical way. You may group it by body system. Validation is when you compare the data you have with another source to determine it's accurate. So you interpret the data, you're looking at it going, okay, what does this mean? And then you validate it by going, okay, what else backs this up? What other information do I have that will confirm this? This all helps you open the door to get more information when you do the health history. It helps you to determine what you need to clarify. And you need to make sure you record it in a clear, concise manner using appropriate terminology. Okay. You want to make sure you're using the right words and not just, unless you're quoting the patient. If you're documenting what the patient says, though, make sure you put it in quotes. Because the patient's going to say something and the doctor's going to be like, what? And you're going to go, oh, it's this. Be factual and very descriptive. Again, recording subjective data in quotes. And don't forget, if it wasn't documented, it wasn't done. So you could do all this great assessment, but if you don't put it down, you never did it. Okay? So things that helping you recognize data clusters. You're looking patterns and trends. The patient's uncomfortable and remains still in bed. So he grimaces, he limits turning, mobility is limited. Knowledge about post-op care. So he asks questions about restrictions and is concerned about the incision site. They're not sure about dressing care, asks about risk of infection. And then they appear anxious or uneasy or make poor eye contact at times. They're restless. They ask good questions. So that is kind of basically the nursing health history. Now, oh, we're almost done, so I'll keep going. I was going to stop for a minute, but we're almost done. Concept mapping. I'll be honest, guys, I have a lot of difficulty sometimes with concept mapping, but I did include information in the files. So when you look at the files for this in Teams, you will see concept mapping. You'll see one that was already created, and you'll see the blank one. We're going to be using that, and I'm going to be working on it myself. So this is where you put all the data together in, and it gives you a visual representation to show connections. So for instance, in this one, you have a 42-year-old male patient with a right femur fracture. You may have your subjective assessment data and your objective assessment data. Then you've got pertinent labs, any concurrent health problems, so things like that. Even in the subjective data, you could break those down into, maybe you would take the subjective and objective and put them into body systems. So you might do vital signs, you might do pain. So with the pain, I would say you could do one that says pain, and you'd put complaint of right leg pain, and you would put moaning. That would be in your pain. Um, you've got, oh, maybe your blood pressure of 150/68. Maybe his blood pressure's up because he's having pain. So that's definitely something you're like, oh, that's something I need to hone in on. That's something that I really need to address for this patient. You may have a patient say, for instance, I think the example is COPD. So you might look at respiratory, you might look at cardiac, and use those different systems connected to your patient with an admitting diagnosis. All right, the nurse process organizes your approach to delivering care. So to provide care, you need to incorporate the nurse process and A, decision making, B, problem solving, C, the interview process, or D, intellectual standards. So good job. It is interviewing. Because the interview process is integral to patient-centered care. It's continuous throughout your interaction, so you're always doing that. And it doesn't matter where you're at in the nursing process, you're always interviewing. So, excuse me. So, the interview process and getting to know your patient and developing that relationship is important because you're going to do it through the whole nursing process while you take care of that patient. So, all right, guys, I'm going to have you take a quick 10-minute break. So 9:40, be back. We're getting ready to do the chapter on mobility. So get up and move it, and stretch your legs, get something to eat, get something to drink, go to the bathroom, take care of your kids, put in a new movie. If they're done with the old one, change the channel. And then we'll be back here in 10 minutes. So 9:40. Sorry, I missed that, Alicia. I would just hang on and just stay there. That's what I've been doing. So for those who might still be there, I am. Please make sure you've got Kahoot because we're gonna do a Kahoot when we come back. If I could spell. Yes, Alicia, it's very kind of sort of a game. You guys create an account, log in. You will need a pin, and I will give you that code here when I click the play button. It will come up with a pin number. Okie dokie. So let me see, are we all back? One, two, three, 4, 5, 6, 7, 8, 9, 10, 11. Yes, Natalie, you can. 12, 13, 14, 15, 16. Okay. So it looks like most everybody is back. So if you don't, I know those of you who are with Dr. Carp, y'all probably have Kahoot on a device. So those who were online only, bummer for you. If you can, as you can see, it's just kahoot.com, or you can go to your app store on your phone and use your phone. It's the only time in class you're going to be allowed to use your cell phones, even in person. So I'll give you a couple more minutes to get Kahoot set up, get logged in, and then we're going to do a quick Kahoot on the chapter we just did. You'll have to create an account, Mercedes. I don't have the pin yet, Isabel. I'm waiting for everybody to get Kahoot. If you go to their website, mercedeskahoot.com, and then create an account. It'll be on my screen too. So one of the things that when you're logged into it, you type in your answer to the question or pick the answer to the question. Oh, nice, Christina. Thank you. All right, you guys ready? So the pin is 1821621. 1821621. Can someone help Natalie? I'm not sure on your end where you enter the pin. Thank you, Jessica. think there's just 2 more of you that might need to get in. No, 3. So if you go to kahoot.com and look for the play and then type in the pin number. I actually just lost people. Or you can go to kahoot.it. Yes, Veronica, there's 29. I know one of your classmates was not able to be here today. So I know there's 28, should be 28 of you, and when I checked, everybody was in except for that person. So we're good. Oh, I lost another one. Thank you. My apologies, guys. I should have made sure we had all this set up before we started today. My bad. I should have 28 players when all is said is done. When blah blah blah. When all is said and done. Anyone else who's having difficulty getting in? Okay, so I have a couple more that we're going to do today, Kahoot, after each chapter. So I want to make sure you guys are able to get in, but we'll get started because we do have a couple more chapters to go over and there's lots of information. So here we go, guys. 10 questions. I gave you guys a whole minute because this is long answers. What is an example of a step of nursing assessment? Comparison of data with another source to determine data accuracy, complete documentation of observational information, or determining which meds to administer based on a patient's assessment data. So the answer was the comparison of data with another source to determine accuracy. Data validation. Oh, I'm sorry, Hayes. Remember, complete documentation, you're not going to just document observational information. So that's where these questions get tricky because it's very specifically about observational. Next question. Which of the following is a source of data in a nursing assessment? Your textbooks, the internet, a family member, or the patient's uncle's brother's sister's cousin's roommate? Yep, family member. Textbooks, you guys aren't totally wrong, but I was looking more for more specific, and I think I'll change that question. I should say a secondary source. But so yeah, I was looking for a family member. That's going to be your more valid source. Anyone get the Spaceballs reference in that question? The assessment step of the nursing process involves decide if goals were met, identifying health problems and resident or patient needs, getting information about the patient and reviewing it, or setting goals and creating a care plan. Yep. Getting information about the patient and reviewing it. So, data collection and then data validation and interpretation is the first step. Identifying health problems and needs, you're going to come up with in the next step diagnoses. And then setting goals and creating a care plan is actually going to be in the third step of the nursing process. During the assessment phase of the nursing process, the nurse develops a care plan to meet the patient's nursing needs, begins to formulate plans for providing nursing intervention, establishes a nursing diagnosis for the nursing care plan, or gathers, organizes, and documents data in a logical database. Good. Yes, it's gathering, organizing, and documenting data on a logical database. Beginning to formulate plans for nursing intervention, again, comes later. And then developing that care plan, again, comes later in the process. First, you need to get the information before you can develop it. Oh, Natalie, you need to see Spaceballs. It's a great movie. It's funny. Mel Brooks. What is the abbreviation for the nursing process? TTYL, SBAR, ADPIE, or SMHN? Yay! If nothing else, you guys know the nursing process standard of practice. This one I didn't talk about, so we'll see. Which assessment category is the top priority? Fluid regulation, oxygenation, wellness maintenance, or nutrition? Very good. Very good. Oxygenation, for sure. That is your top priority because without oxygen, you are not going to function. So you need oxygen. Remember, if someone's not breathing, then the first thing you want to do is make sure they get oxygen circulating. So remember, CPR, it used to be airway, breathing, circulation. Now it's circulation, airway, and breathing because the blood already has oxygen in it. It just needs to get there. So making sure things get oxygenated is always a top priority. A nurse will arrive at a nursing diagnosis through the nursing process step of planning, research, evaluation, or assessment. I need to give you guys some more time. It's assessment, guys. So remember, evaluation's the very last step that you're going to do. So first it's ADPI, assessment, diagnosis. So you get to your nursing diagnosis through your assessment. Then you plan and you implement and then you evaluate. What type of assessment gathers more specific details about a patient's presenting concern? The initial, the focused, time lapsed, or emergency? Yes. So the focused assessment. So focused is more specific. You're getting drilling down to the nitty gritty. So that's where you're going to get your more specific details about the concern. The initial assessment is okay, what's going on? The other two just don't get very specific and aren't really ones that you will use. Although emergency you will. But then with an emergency assessment, you're going to be focused. Almost done. Two more questions. So, asking a patient about their sleep habits occurs in which phase of the patient centered interview? Orientation, the working phase, data validation, or termination? Yes. So the orientation phase, guys, is when you're getting to know, you're introducing yourself. Hi, how are you? I am your nurse. The working phase is where you're actually getting specific information, like about a patient's sleep habits. And then data validation is actually not a phase in the patient center interview. So you start with the orientation phase where you tell the patient who you are, what you're doing, and what you're going to talk about. The working phase is what are you talking about, the specific questions that you have, and termination is where you summarize everything and then give them a cue that you're ending the interview. Last one. What type of interview question do you first use when assessing a patient? Probing, problem-oriented, open-ended, or confirmation? Yes, open-ended. So when you're first going in, you want to do open-ended questions because that hopefully will allow the patient to give you additional information. Then you'll know how to focus and do more problem-oriented. Confirmation is going to come towards the end where you're just confirming what they've said. Probing isn't really something that you're going to use. It may seem like it though. Oh, hey, Susie, you weren't so wrongo. All right. Good job, guys. Hopefully that works for you guys. And that helps quite a bit. Get you guys going, you know. So, I'm sharing my screen differently. So I want to see if this works. Oh, Kahoot's still going in the background. Hang on. I don't want to hear that. Leave. Okay. Good, Natalie. I'm glad you liked it. So, did you guys hear that? Were you able to hear it that time? Ah, yes. Thank you. Anyways, so I just thought that would be a fun little way to get to immobility. So mobility is actually essential not for self-defense. Yes. Hayes, good. Thank you for letting them know that. So mobility, you use it for self-defense, your activities of daily living. If you can't move, you can't do things, and recreational activities. And a lot of bodily functions actually depend upon your ability to move. So body mechanics is actually the coordinated effort of your musculoskeletal and the nervous system. Uh, Body alignment and posture are very similar terms. Alignment refers to joints, tendons, ligaments, and muscles while standing, sitting, and lying. Posture. Alignment is the center, means that your center of gravity is stable, reducing the strain on your musculoskeletal structures, aiding in adequate muscle tone, promoting your comfort, and contributing to balance and conserving of energy. 28. Yes, thank you. Without balance control, your center of gravity gets displaced and you fall over. Your weight is actually the force exerted on a body by gravity, and that force is always directed down. Friction is a force that occurs in a direction to oppose movement. The greater the surface area of the object moved, the greater the friction. Shear force is shear is force exerted by skin, while the skin actually remains in one place, but the bony structures underneath it move, resulting in damage. Skeletal system provides attachments for your muscles and ligaments, leverage necessary for mobility. You have 4 types of bones: the long, the short, the flat, and irregular. Pretty sure Dr. Cart probably taught most of you this, going back to anatomy, but refresher. The functions of the skeletal system are to protect your vital organs and aid in calcium regulation. Your bones store and release calcium into your blood as needed. Pathological fractures are actually caused by weakened bone tissue. And bone marrow participates in red blood cell production and acts as a reservoir for blood. Your joints are the connections between bones. You have 3 classes of joints. You have your cartilaginous, your fibrous, and synovial. Ligaments, tendons, and cartilage. Ligaments are the white, shiny, flexible bands of fibrous tissue, and they bind your joints together, connect bones and cartilages. They help in joint flexibility and support. Tendons are white. They tend to glisten. They're shiny. They're fibrous bands of tissue that connect muscle to bone. So ligaments connect joints together. So bone and bone, bone to cartilage. Tendons connect muscle to the bone, and they're very strong and flexible. Cartilage itself is not vascular, and it just supports connective tissue. It's supporting. And the characteristics of your cartilage change with age. In fact, you can lose cartilage. Skeletal muscles are actually your working elements of movement. That's what helps you move. Your nervous system will regulate your posture and your movement. This is why you need bones. Natalie, they do kind of grow slowly, but eventually, think about the cartilage in your joints, though, more. We're talking more bony skeletal cartilage, so the cartilage in your knees, that provides a cushion, and that cartilage breaks down over time due to wear and tear. So when I'm talking about this cartilage, I'm talking about cartilage of joints, not necessarily the cartilage in your nose and your ears, because they're not joints. So glad you guys like that. I love that. It was like, okay, Harry Potter reference time. So postural abnormalities that you can have, they can be congenital. So you're born with it, or you can acquire them. So bad posture can actually, lead to that, or you can have a fracture that happens. You're going to look at alignment and range of motion. So we're talking things like foot drop, scoliosis, congenital hip dysplasia, bow-leggedness, knock-kneed, and pigeon toes. So you see there the picture, you have your scoliosis, which your spine curves to the side, kyphosis, which gives you a hunchback, and then the lordosis, which is in the lower back, which makes your booty stick out, kind of like a Kardashian. Muscle abnormalities you might have are dystrophy or disuse. And thank you, Veronica. So muscle abnormalities, like disuse abnormalities, causing these deformities. Damage to your central nervous system can affect your voluntary movement. So you have impaired body alignment, balance, mobility, and just mobility in general. So we're thinking things like a head injury, stroke, infection like meningitis. And then trauma. So direct trauma to your musculoskeletal system. Bruises, contusions, sprains. Y'all know when if anyone's sprained their ankle before, you can't really walk on it. Sometimes you have to do crutches. That's affecting mobility. Fractures. When I was 11, I was hit by a car on my bike and I fractured my left femur. So I was in traction for 3 months. You can probably guess I had some muscular atrophy and difficulty in mobility once I got out of traction. So it took a lot of therapy. Also, now my left leg is about 1/4 of an inch shorter than my right. So other factors that can influence mobility, your metabolic system. So changes in mobility alter your endocrine system, your metabolism, calcium absorption, and the GI tract. Metabolism is important to help you maintain function. The endocrine system regulates your internal environment. If you're not mobile, that decreases your metabolic rate. You have weight loss, decreased muscle mass, and weakness. Also, because it affects the functioning of the GI tract, you end up with constipation and can have fecal impaction. In the respiratory system, you're looking at things like atelectasis, which is a collapse of the alveoli in the lungs because your lungs aren't inflating appropriately. You can end up with hypostatic pneumonia, which is an inflammation of the lungs from stasis or pulling of the secretions. Yes. Cardiovascular, orthostatic hypotension. When you change positions, your blood pressure drops. You have an increase in your cardiac workload. And you have thrombus or blood clot formation. Orthostatic hypotension, hypo, guys, so that's low blood pressure, is a drop of greater than 20 millimeters mercury in the systolic pressure, or a drop greater than 10 millimeters mercury in the diastolic, which is the bottom number. Signs of orthostatic hypotension can be lightheadedness, nausea, tachycardia, so elevated heart rate, pallor, which is becoming pale, or fainting when you change positions. Thrombi are accumulations of platelets, fibrin and clotting factors, and cellular elements of blood. They attach to the interior wall of a vein or an artery. Sometimes that causes an occlusion or a blockage of the lumen of the artery or vein. 3 factors that contribute is damage to a vessel wall, alterations in blood flow, and alterations in the blood constituents. That is called Virchow's triad. So damage to the vessel, alterations in blood flow, and alterations in blood constituents. So what the parts that make up blood. The musculoskeletal factors, they can be permanent or temporary impairment or disability. Some muscle effects, the protein breakdown, so you get loss of muscle mass, disuse atrophy, and loss of endurance. Skeletal effects, you can get disuse osteoporosis, where your bone tissue is less dense, which increases your risk for pathological fractures. So the three factors of Virchow's triad, it's the alterations of blood flow, damage to the vessel wall, and the last one is alterations in blood constituents, so things that make up the blood. Back to musculoskeletal. So again, skeletal effects are the disuse osteoporosis, which can lead to pathological fractures. And then you also have joint contractures, where it can be possibly permanent fixation of a joint. And it can be, usually contractures means it's bent up in some way, shape, or form. The urinary elimination changes, urine backs up. It's stasis. It increases the risk for urinary tract infections and also increases the risk of renal calculi or kidney stones. So that's something you need to monitor. Integumentary pressure ulcers, biggest one, usually due to decreased blood supply because you're not moving. And then tissue metabolism depends on oxygen and nutrients from the blood, which is why blood supply is an issue. And then you also have the psychosocial effects of immobility. You get emotional and behavioral responses, sensory alterations, and changes in ability to cope. Patient might feel social isolation and be lonely. They develop depression. So those are all issues that you need to assess for when you're looking at someone with mobility or issues. So you notice a respiratory change in your immobilized post-op patient. The change you note is most consistent with A, atelectasis, B, hypertension, C, orthostatic hypotension, or D, coagulation of blood. Okay, guys, so I am going to help lead you down the path. You've got a respiratory change. Coagulation of blood, does that seem like it's a respiratory change? Could be if they have a blood clot, but not likely. It's not one that you're going to notice. Orthostatic hypotension, is that respiratory? Right. Hypertension, is that a respiratory issue? Right, Courtney, it's blood pressure. Okay, so the answer is A, atelectasis, because atelectasis is what? Who can tell me what atelectasis is? Nope, that's ascites, Veronica. Yes. So atelectasis is when the alveoli in the lungs collapse. So they squish together and that decreases the amount of surface area for the oxygen to be exchanged in the alveoli. Developmental changes. So these are also issues with mobility. So in infants, toddlers, and preschoolers, the musculoskeletal system is developing to support weight for standing and walking. They have awkward posture because of their head and trunk, which is generally carried forward. Their center of gravity is off, so that's why toddlers fall. And then prolonged immobilization can lead to delay of gross motor skills, intellectual development, and musculoskeletal development. So if an infant, toddler, preschooler it has to be immobilized for any reason, for any length of time, you can have delays in their development with their motor skills and intellectual. Adolescence, that's a period of a lot of growth. If you reduce activity, they can end up behind with peers in gaining their independence and accomplishing certain skills. Social isolation of immobility is definitely an issue with adolescents. Um, the growth is big, it can stunt their growth and cause issues there. In adults, you have periods of prolonged immobility are a risk to all of their physiologic systems. There's also family and social structure changes. There can be a loss of a job, which can affect your self concept. And then older adults have progressive loss of bone mass, so their bones are weaker. If they fall, that's bad. They become less coordinated. Some of their medications may also make them at higher risk for falling. And with older adults, you want to make sure you encourage them to perform self care. So, assessment. You've got to consider what normal mobility is, the effects of disease on their mobility, and the effects of their treatment on their mobility. Mobility generally is going to focus on your range of motion, gait, exercise, and activity tolerance, and then body alignment. So you're going to begin your mobility assessment with your patient in the absolutely most supported position and then move to higher levels according to how the patient tolerates it. So they may start laying down, they may start sitting down, and then you're going to move. Range of motion is the maximum amount of movement available at a joint in one of three planes of the body: your sagittal, transverse, or frontal plane. So range of motion, maximum amount of movement available at a joint at one of three planes in the body. So what joints are you going to look at? What joints are you going to assess the range of motion in? Shoulder, arms, legs, hip. Be more specific. Mercedes. What joints in the arms and the legs? Shoulder and knee. Good, Sean. Wrist. I see wrist. Ankle. Great minds think alike there. You guys got the pretty big ones. Thank you, Natalie. Neck. There was one that I was waiting for. So yeah, you're going to assess the range of motion of your neck, shoulders, elbow, forearm, because your forearm does move, the wrist, your fingers even, thumb, because that's not a finger, thumb is its own little world, hip, your knee, your ankle, the foot, and toes. Your gait is your manner or style of walking, and it is a coordinated action. So you're going to watch how someone walks. Do they limp? Do they favor one side? Do they shuffle their feet so they don't actually lift their feet up off the floor? They just kind of shuffle along. Exercise is physical activity used to condition the body, improve your health, and maintain fitness. Activity tolerance is a type and amount of exercise or work that you are able to perform without undue exertion or injury. Excuse me. So that undue exertion or possible injury is really important, guys, because some people go a little bit too far and they can end up injuring themselves. So you need to be careful with your patient in teaching them about exercise and talking about exercise. Body alignment, you're going to want to assess that with the patient lying down, sitting down, and standing up. So when they're standing up, is their head erect and midline? If you look at them from the posterior or from the back, are their shoulders and hips straight and parallel? So are the shoulders over the hips? Is their vertebral column straight? Is it kind of curved? When you look at them laterally, so from the side, is their head erect? The spine curves are aligned in the reverse S pattern. Cervical vertebrae are anteriorly convex, so your neck will actually kind of curve towards the front of your body. Thoracic spine should be posteriorly, so curving towards the back. And then the lumbar also, once again, comes into the through the front. Is the abdomen tucked in? And are the knees and ankles slightly flexed? And does the patient appear comfortable standing? Are their arms comfortably hanging to the side? The feet slightly apart, toes pointed forward. And then when you look at them from behind, is the center of gravity is midline. The line of gravity goes from the forehead to the midpoint between the feet. And then laterally, it'll run vertically from the middle of the skull to the posterior third of the foot. When a patient is sitting, their head is erect. You're going to look at, is their head erect? Are their neck and vertebral column in a straight alignment? Body weight distributed evenly on the buttocks and thighs, so they're not leaning forward or anything else on one or onto one side or the other. Thighs are parallel and in a horizontal plane. Both feet are on the floor and ankles are flexed. There should be a 1 to 2 inch space between the edge of your seat and the popliteal space on the back of the knee, believe it or not. So you need to have that 1 to 2 inches and make sure when they're sitting, their feet are on the floor and their ankles are actually flexed. Their forearms might be supported on armrests, in their lap, or on a table. When they're lying, you're going to assess them in the lateral position and remove all positioning support, so except for the pillow under their head. So you're going to look at, you're going to remove pillows from under their hips and other joints, unless it's contraindicated. So things you're going to ask your patient, hey, tell me about your normal activity. Has it changed at all recently? Because has their illness affected their activity level? How are your appetite and diet since you started having problems moving? What do you eat in a normal day? Does the day seem very long? Are you sleeping at night? People who are immobile generally have difficulty sleeping. Have you noticed any places on your skin that are red, or do you have any open sores? And any changes they've noticed in urinating and or bowel movements? So, guys, while you're watching this video, I want you to stand up. Yes, everybody stand up. You're going to do range of motion exercises, okay? Y'all ready for this? So I know those are quick little video, guys, and they went kind of fast. And she actually called one, I think the wrist, she called it elbow, but it was the wrist. So I also like that because I figured it was a good way for us to get up and do things while we're doing class. So, but it is in the lecture slides, so you can pick it up there. If you want me to post the link, I can post that later too. So other things in the process, you're going to look at measuring height, weight, skin fold thickness for metabolic system. So those are the anthropometric measurements, and also to measure muscle atrophy. Because and you notice in that picture on the right with the actual legs with skin on them, the actual patient legs, look at the legs and tell me, do you see the difference? Which leg is smaller than the other? Absolutely. Yes, you guys are right. It is the right. So we can see that clearly here, but sometimes it's going to be very subtle, and that's where those measurements are going to come in. You also want to do an intake and output to check for fluid balance to make sure they're not putting on fluid, which can happen when you're not mobile. If they're taking stuff in and it's not coming out, the fluid's going somewhere in the body. We don't know where. So you need to look at that. You also want to look at their food intake and elimination patterns, again, making sure their bowels and urinary habits are good. You want to do a respiratory assessment at least every 2 hours. So not only do you want to listen to their lungs, but you also want to look at their chest wall movement, because muscles are affected there. And then auscultate the lungs or listen. Cardiovascular assessment, you're going to do the blood pressure. You may do orthostatic ones, so lying, sitting, standing, to see if there's a difference. You're going to check pulses, the apical pulse and the peripheral pulses. So you might do the dorsal pulses on the feet. You're going to do ulnar radial pulses. You're going to observe for signs of venous stasis. And what this is when the blood is pooling in the venous system, so within the veins. It's not returning back to the heart. So what you will see with that is you will see edema or swelling, and if they have a wound, you may see delayed healing of that wound. Orthostatic vital signs during the first few times getting up, because you want to make sure that your patient doesn't have orthostatic hypotension and fall. Your musculoskeletal assessment will look at muscle tone and strength, loss of muscle mass, any decrease in the range of motion, and any contractures. You're going to assess any skin for breakdown or color changes, because it may not be breaking down, but you're going to notice color changes. Important that you use a standardized tool. Usually for skin, we use a Braden scale. You're going to look at the skin. You don't have to specifically go, oh, I'm going to check your skin. Your assistant is going to go in and bathe the patient. Why not go in with her? While you're helping her, you can look at the patient's skin. A lot of assessment you can do while you're doing other things. So you don't always have to go, oh, I'm going to go assess their skin. And you can do multiple things at one time. You want to make sure that you do intake and output every shift, and then cumulative over 24 hours, and compare the amounts. Also checking in bowel elimination, changes in their personality. Are they bored? Are they showing signs of depression or anger? And then make sure you assess the children for milestones, because we want to make sure that they're progressing normally and that they're not going to be too far behind yet. All right, so let's go ahead and take another little 10-minute break. So be back at 10:50. Well, sorry, not 10:50, 10:45. A 9-minute break. So take a quick break, get up, move around some more, practice your range of motion, and yeah, so be back at 10:45. Okay, so we are going to keep going. Next step, we did our assessment. We'll do our diagnoses, which we'll get more into in I think next week lecture, and then we'll plan. Now we got to implement. We've got to plan. So, back injuries are often the direct result of improper lifting and bending. So, we really want to prevent work related musculoskeletal injuries. And I really want to emphasize this with you guys. You are just starting your nursing careers, and you are going to have hopefully very long careers ahead of you, and you need to make sure you save your back. So, one couple things you do: assess the weight of what you're lifting and determine, do you need help? You don't need to be a superhero. You don't need to be Superman. You ask for help. If you're not sure, ask for help. Make sure you have someone there with you. Hoyer lifts, you have to have a spotter. And just save your backs. One big thing you can do to save your back is also make sure you have the bed at the right height for whatever you're doing. So if you're turning a patient, make sure you have the bed at a good height for yourself and the person you're working with. Exercise actually can help enhance your feelings of well-being. It improves your endurance, your strength, and just overall health. It makes you feel good. And then encourage patients who are at risk for osteoporosis to be screened. So they're going to do a DEXA scan or bone density, and then assess for calcium and vitamin D intake. Are they even taking in enough calcium and vitamin D to promote bone health? In the acute care setting, things you're going to do: metabolic. You're going to make sure they're eating a high protein, high calorie diet to help repair, especially surgical patients. You might want to also make sure they're getting vitamin B and C. They may need total parenteral nutrition, which is through an IV. And then, or they might need enteral tube feedings into the GI tract. So, like a PEG tube or a G tube, a tube that goes directly into the digestive system or GI tract in order to help provide nutrition. Respiratory, you want to do things that promote lung expansion and the removal of their secretions. So, they may do deep breathing exercises, use the incentive spirometer, some controlled coughing, chest physiotherapy where you're patting them on the chest. Up there, one of the pictures I have, she's blowing up a balloon for patients who are, maybe you're doing a home health setting. I recommend my patients, when they're having breathing issues, use balloons. They blow them up as big as they can, and that helps it with lung expansion. Cardiovascular, you want to make sure you reduce the chance of orthostatic hypotension. So you want to get that patient moving as soon as their condition allows them to, and also make sure they're doing slow position changes. You want to make sure you're reducing their cardiac workload. So avoid using Valsalva when moving up in bed, straining. When they're defecating or when they're lifting. And that's when they hold their breath and they strain. And that is when they release, it creates a rush of blood, which can cause them to have hypotension. You want to prevent thrombus formation. Thrombus formation in a hospital setting is what's called a never event. In other words, it should never ever happen because you should be doing these things. So DVT is a deep vein thrombosis or clot. To prevent these, you might have a patient on anticoagulants. They might be on aspirin. They may be wearing compression stockings, also called TED hose. They may have the intermittent pneumatic compression devices or sequential compression devices, SCDs, and that's what you see there in the top picture. In the sim lab on actual campus, the sim patient actually has SCDs. And you also want to teach them to do foot pumps. So, excuse me, where they're moving their feet up and down. So dorsiflexion, plantar flexion. One way to do this is to have them write out the ABCs with their feet. You want to make sure that they are positioned properly to minimize compression of veins, and then also do range of motion exercises to keep their vascular system running. Musculoskeletal, again, range of motion and exercises. If a patient is not able to do active range of motion where the patient does it themselves, then you want to do what's called passive range of motion where you move that joint through the range. It also helps prevent contractures. Skin, you want to make sure you're turning and positioning your patient, using therapeutic surfaces, so special mattresses. Limit uninterrupted chair time to 1 hour. You don't want your patient sitting in the chair solid for 1 hour. If they're getting up to the bedside commode or moving in any way, that's better. And a patient needs to shift their weight in the chair every 15 minutes. So we want them to kind of shift to the left, to the right, to the middle. For the GU and GI, so elimination, you want to make sure they keep well hydrated and you want to increase their fiber so that will help their bowels move. Psychosocial, provide the patient with a routine. Make sure they get informal socialization, encourage visitors. When you're doing your rounding, make sure you're interacting. As much as possible, try to minimize their sleep interruptions and then give them some meaningful stimuli and interaction. Developmentally, again, mental and physical stimulation. If you can, put children of the same age together unless there's a contagious illness. Encourage visiting from family members, and then let older adults perform ADLs as many ADLs as possible. It's easy to get into the here. Let me do that for you because it's quicker, and you need to get on to your next patient. But try not to do that, and make sure that your patient is allowed to do things, even if they are a bit slower. Some positioning, you might use a trochanter roll. That prevents the external rotation of the hips when the patient is supine. Now, way I remember is it supine on spine. So supine is when they're laying on their back. Pronation is laying on their belly. So you're going to roll up a blanket lengthwise to a width that goes from the greater trochanter of the femur to the lower border of the popliteal space. And you can kind of see it in that top picture. Place a blanket under their buttocks and roll it counterclockwise until the thigh is in a neutral position or inward rotation. Their patella should be facing up. They also may have a trapeze bar, which attaches to the bed frame, and this helps the patient pull with their upper extremities to get their trunk off and allows them to assist in transfer from a bed to a wheelchair or to actually do upper arm exercises. Supported Fowler's position, where the head of the bed is about 45 to 60 degrees. Their knees are slightly elevated without any pressure. This supports the need to permit flexion of hips and knees and proper alignment of normal curves of the spine. However, common areas of a problem: increased cervical flexion, thrusting the head forward because they are the pillow underneath their head. Also, extension of the knees, if it allows the patient to slide to the foot. So you notice in this picture, the patient on the bottom, the knees are slightly bent on the bed, and that keeps them from sliding down the bed, which causes friction and shear and can lead to skin issues. You want to make sure you watch the pressure on the back of their knees because that can decrease circulation to their feet. It can cause external rotation of their hips, so their hips are moving outwards. Arms can hang unsupported. Feet are unsupported or there's pressure on their heels. And then you have unprotected pressure points at the sacrum and again their heels. And again, we can increase shearing force if the head of the bed is over 60 degrees. So more positioning, like I said, supine on spine. They're laying on their back. The mattress needs to be firm enough to support their entire spine and their shoulders. They need to have a foot support to prevent foot drop. Common areas are pillow at the head of the bed, increasing flexion, or the head flat on the mattress. Shoulders are unsupported and internally rotated, so in towards the chest. Elbows are extended. Thumbs are not in opposition to their fingers. Hips get externally rotated. Unprotected feet and unprotected pressure points at the occipital of the head, so the very back of the head, vertebrae, coccyx, elbows, and heels. Prone is when they're lying face down. Their head is usually turned to the side, and their pillow needs to help prevent cervical flexion. You end up with trouble points at neck hyperextension, hyperextension of the lumbar spine, plantar flexion of the ankles. As you can see in that picture, the patient prone, their feet are plantar flexed. And then unprotected pressure points happen at the chin, elbows in women, in the breast area, hips, knees, and toes. And also when they're laying like this with their head flat, the ears. Then you have side lying or a lateral position, where they're on the side with the major portion of their body weight on dependent hip and shoulder. So on the bottom hip and shoulder. 30-degree lateral recommended for patients at risk for pressure ulcers. Trunk alignment should be the same as standing. You end up with lateral flexion of the neck, so side to side. Spinal curves are not in alignment. Shoulder and hip joints are internally rotated, adducted, or unsupported. No foot support. Protection of pressure points, so you don't have that. The ears, shoulders, anterior iliac spine, trochanter, and your ankles. And if the patient has large hips and a pillow is not placed superior to the hips, you may end up with excessive lateral flexion of the spine. Then we also have the Sims position, which is that last one, the cartoony looking one. The patient puts their weight on their anterior ilium, humerus, and clavicle. Trouble points are lateral flexion of the neck, internal rotation, adduction, or lack of support at shoulders and hips, lack of foot support, and lack of protection for pressure points at the ilium, their humerus, clavicle, knees, and ankles. When you're moving patients, use safety first, guys. Make sure you're doing it safely. Determine what your patient can do. Does moving them or mobility is it contraindicated by their illness? And do they know what they're supposed to do to help you? So always ask your patient to help to the fullest extent they possibly can. Again, determine how many people you need to help. Assess your own strength. And if the patient is too heavy or immobile for you to move alone, ask that question. Are they too heavy? Can I move them by myself? Restorative care's goal is to get the patient back to the maximum functional mobility and independence. IADLs are independent ADLs, so they're activities that are necessary to be independent in society, not just eating and grooming and transferring and toileting. We're talking things like shopping, preparing your meals, banking, taking medications, cleaning your house. You need to work with your patient in order to set up goals. So range of motion helps to ensure joint mobility. You do the passive range of motion, so you are putting the joints through the range of motion when the patient is not able. And you want to begin passive range of motion as soon as you can. You don't want to lose that joint. You're going to use smooth, slow movements just to the point of resistance. That is a very big point. You only move a joint when you're doing passive range of motion to the point of resistance. If you go to the point of pain, if the patient complains of pain, you've gone too far. Never force a joint beyond the capacity. Repeat each movement you do 5 times during any session. You want to stand on the side of the bed closest to the joint being exercised and do it in a head to toe sequence. So maybe you start with the neck, then you move to the shoulders and the elbows and the wrists and the fingers, and then down to the hips. When walking, you want to assess the patient's activity tolerance. their tolerance to being upright, the amount of strength, do they have any pain, their coordination, and their balance. And determine if you need any assistance when walking the patient. Maybe you're going to stand beside the patient and you're going to have your tech behind you with a wheelchair in case the patient needs it. Explain how far they will go. Explain to them who will help them. Tell them when it's going to happen. Okay, Mr. Jones, I'm going to be back in half an hour and we're going to go for a walk. We're going to go halfway down the hall and back again, and I'm going to have Davina assist me. And tell them why it's important. We want you to keep mobile. We want to keep muscle strength, all that. You're going to make sure you check for any obstacles in the way. You're going to establish rest points or have someone follow with a wheelchair. Use a gait belt. That helps the patient's center of gravity remain in the midline. And then use other assistive devices as needed. For instance, you are going to use a walker maybe, or a cane. So in those pictures, what you're seeing is how to help a patient fall, kind of. You're not going to let them fall. You're going to guide them to the floor if that happens. And note that they are using a gait belt. So here's a little video on how to assist a patient to fall. You are the nurse. So you can see in that instance, guys, what she did was he started falling forward, so she pulled him back towards her and guided him, did a wider stance for herself, and used her forward leg to help guide him down to the floor. She didn't try and pick him up. She didn't try and lift him. If the patient's falling back, if they're leaning into you, you'd same thing, widen your stance and use your leg to help them guide to the floor. Don't try and, you might want to hold them and keep them from falling too quickly. Absolutely. And this is why gait belts are so important. It gives you something to help hang on to when you're with your patient. Oh. So he's walking, and then, he falls forward, and she slides him down. Don't try to prevent the fall. Try to make sure they get safely to the floor. You're welcome. Again, if you have the PowerPoints, the links are enabled, so you should be able to watch these again if you need to. So, evaluation, important thing, patient outcomes. Now we're at the end of our care plan. And does the patient feel that the goals were met? It's very important that you ask your patient. First of all, hopefully you set the goals with your patient. So, hey, do you feel like they met them? Are your expected outcomes the same as your actual outcomes? So you set outcomes that you thought would happen, but did that actually happen? Or did something different happen? Or did nothing change? This is where you assess your effectiveness of your interventions. Were they effective? Did they work? Did they not work? If they didn't work, why? So again, then if your outcomes weren't met, why weren't they met? What did we do that wasn't effective? How can we change it? And this is where, if you meet your goals, great. This part of the care plan's done. If you don't meet your goals, you're going to revise it and see if you're going to, maybe you're going to change your interventions, or maybe you're going to set your time frame a little bit differently. So that's the end of this chapter. We'll go back and we are going to do another Kahoot. I think this one's shorter. Yeah, it's only 9 questions. Okay, guys, join on into Kahoot. That's not really, oh, there we go. Direction I want to go is like 22, 23, 22, 23. A little bit more time. All right. Whoops. All right, we're going to get started. Metabolic effects of immobility: decrease in muscle tone, atelectasis, calcium shifts from bone to circulation, or decrease in peristalsis leading to constipation. Multiple answers on that one. Trixie. So decrease in muscle tone, calcium shifts, and decrease in peristalsis. Musculoskeletal effects. Multiple answers, guys. My apologies for being tricksy before. So musculoskeletal contractures, which is a joint issue, and pathological fractures, which is bone. Oxygen and peristalsis generally don't have to do with the musculoskeletal system. Immobility can damage bones by weakening structure, leaching calcium from the bone, causing stress fractures, or any all of the above. Good job. Any all of the above. Yes. So immobility causes weakening of the structure, which is due to leaching calcium from the bone, which then causes stress fractures. So all of the above. Immobility of the GI system can cause constipation, nausea, vomiting, hypermotility, or stone stomach, or multiple. Constipation. Yay, good job, guys. Everybody got it right. Yes, it leads to constipation due to decrease in peristalsis. Ooh, urinary system. Immobility in the urinary system can cause renal calculi, more alkali urine, UTI, or any all of the above. This is a single answer, guys. That kidney stone looks really, really painful. Yep, any all of the above. So, yes, renal calculi is right. You're right. I did say kidney stones. I did mention urinary tract infections also, but it also causes urine to be more alkaline because of the breakdown of electrolytes. So that's another thing to keep in mind. You might want to watch the patient for alkalosis, and that actually we discuss later on in the another lecture. Immobility affects which system of your body? Nervous, musculoskeletal, urinary, or all of the above? Perfect. Yes. What is one effect mobility has on the musculoskeletal system? Contractures, nourishes joints, maintain bone density and strength, or increase joint flexibility. Yes, contractures. It does not maintain bone density and strength. And it does not increase flexibility. If you're not mobile, you're not flexible. That's why you need to keep doing range of motion exercises. Yeah, Tim, I'm pretty sure that was not a picture of you. What can happen to skin if there is reduced perfusion because of immobility? Acne, jaundice, dryness, or skin breakdown? Skin breakdown, guys, is the most common complication due to risk, and the one with this one is because it talks about reduced perfusion, so decreased blood flow to the skin. So dryness, yeah. Jaundice, that's a liver disease, so that's something we'll talk about later. But skin breakdown, if there's no perfusion, your skin starts breaking down because it's not getting oxygen and nutrients. And no, Tim, that was definitely not you 10 years ago. Last question. When performing range of motion exercise, move the joint until there is resistance, you hear a pop, or the patient reports pain. Yes, resistance. If you hear a pop, you've gone way too far, and that's a problem. You probably just dislocated their joint. And remember, I said, do not move. If the patient says pain, you've gone too far. So you want to move the joint to the point of resistance. Yay, Longo was not wrongo. Good job, you guys. All right, good job. So our next chapter we're going to start now is chapter 30. If there's pain before resistance, Nathan, stop. If they have pain, stop. Don't go any further. Pain is a sign that there's a problem or damage. Chapter 30, Natalie, I know it's an extremely important one. So there's a lot to it. So chapter 30 is all about vital signs. So you've got your heart rate, blood pressure, oxygen sats, respiration, temperature. These are all indicators of a health status. So you're looking at the circulatory system, the respiratory system, the neural system, so neurologic system, and also endocrine function. Factors that can affect your vital signs are the temperature of the environment, physical exertion, or even the effects of illness. Usually, alterations in vital signs indicate a change in physiologic function. So, if vital signs is changing, there's something physiologically going wrong. And it is a very quick and efficient way in order to monitor patient's health status. So guidelines, you can delegate. Jesus, that's so sweet. You can delegate vital signs, and I know some of you guys are techs or MAs and you get delegated how to do vital signs. But in the end, you are the one who's responsible for making sure they are done and that you actually saw them. So it's important that you are aware and make sure that your tech or whomever knows that if they see an abnormal, to please let you know sooner rather than later. Okay. Another thing, don't use a regular size cuff on a large person. Okay. You need to make sure you're using the right size. Knowing the patient's usual range helps you give a baseline. So some patients will know what their normal range is, or sometimes a family member will know, especially with children. For instance, my husband's temperature, blood pressure, pulse, usually they all run on the lower end. So temperature, for instance, he runs 96, 97. Well, if his temperature is 99, that's at least a 2 to 3 degree rise in temperature. If he was at 98.6, that 2 degrees would then make him 100.6, and we consider that a fever. But because his baseline is so low, no one catches that he has a fever. So it is important to try and gather from your patient what their normal range is. Some illnesses will cause a predictable change in vital signs. Others don't. Medications can cause a change in vital signs. Antihypertensives, antipyretics like Tylenol. So, who can tell me when would you get vital signs on a patient? You're the nurse, keep in mind. When would you do things to check the patient's vital signs? At what time? In the morning, it depends, every 2 hours. Beginning of the shift. Assessment. Before blood pressure meds. Admission. New signs and symptoms. Pre and post. Oh, Alicia, good one. Great questions, Tim. So, in those situations, what would you do? Patient just came from surgery. While they're in surgery, they're in the intensive care unit. How often? Well, every 15 minutes. Awesome, you guys. So yeah, when they're admitted to the hospital, you're going to do admission. Yes. Well, Veronica, there's not really a tip or trick that I can really help you with. You might want to try using another limb other than an arm. That might help. We can also work on, when we get to the skills lab, that's definitely something we can work on together. Larger people are harder because you have more fat blocking the vessel. So you really kind of have to press in and listen. And again, sometimes you might have to use a different limb, like their leg, to be able to hear a better blood pressure. So times that you will take it. That's a good one, Alicia. Making sure you minimize the amount of noise in the room because you have to listen very carefully. Ask the patient not to speak because you need to listen. For sure. So you guys all came up with pretty much everything. Admission, you're going to do them at home care visits, in the hospital on the routine schedule. So every shift or whatever the schedule or order is. before and actually during and after a blood transfusion. So you're going to do you're going to do the vital signs before a blood transfusion. You're going to start the blood transfusion and recheck them in like 5-15 minutes. And then after the blood transfusion. Before, during, and after giving meds or therapies that can affect your cardiovascular, respiratory, or temperature controls functions. Anytime the patient's condition changes. Before, during, and after any nursing interventions that can affect vital signs. And if the patient reports any symptoms of physical distress. So awesome job, you guys. Acceptable ranges. So acceptable ranges, these are for adults. And that's basically because we're not really specializing here in like peds or newborns. So this is what we're going to go by. Average temperature range for an adult is 36 to 38 degrees Celsius, which would be 96.8 to 100.4 Fahrenheit. They also have the oral, rectal, and axillary. So I'd like you to note that the oral and tympanic temperature is actually about a half a degree less than the rectal, which is more of a core temperature. And the axillary is even less than that. Pulse rate should be anywhere between 60 to 100 beats per minute and very strong and regular. Pulse ox greater than 95%. Keep in mind with a pulse ox on a patient who's not on oxygen, you should not have a 100%. The air we breathe is only 21% oxygen. So getting 100%. Yes, Adriana, and you will get those when you are in peds. So it is, but we will actually discuss that a little bit. But yeah, for the purposes of this class, we're using more adult, and in pediatrics, you're definitely going to need to memorize the children range. And there is a couple questions might be on a quiz or test. So oxygen sats, unless they're on oxygen, they're not going to be 100%, nor should they be. However, things that can affect oxygen sats are smoking, that can artificially inflate it. Respirations should be 12 to 20. They should be deep and regular. Blood pressure, should be less than 120 systolic and less than 80 diastolic. That is actually per the new JNC 9 guidelines. And then capnography looks at your CO2 level, and normal is 35 to 45. Body temp. So there is no single temperature that's normal for everybody. Most people vary by their temperature. Core temp is the temperature of the deeper tissues. The site of where you take their temp and the time of day that you take it can affect it. Hormones can affect temperature. That's why women use temperature for ovulation prediction. But the problem with getting a core temp is it's invasive, whereas surface temperatures are not. So we use thermoregulation, which is the balance between the loss of heat and the amount of heat produced, which is controlled by neural and vascular systems. So big thing to remember, this may be on a test, your hypothalamus controls the body temperature. So if something happens to your hypothalamus, say you have a head injury and you're assessing that patient, you might want to make sure you pay particular attention to the temperature because it's going to be affected. You sense the minor changes. The anterior hypothalamus controls your heat loss, and the posterior controls the production. Okay. Pyrogens are produced by cytokines during an immune response. Well, actually, they're produced by the bacteria. Yeah. And disease or trauma to the hypothalamus can cause major alterations in temperature control. Heat production is heat that is a byproduct of metabolism. It can occur during rest, during voluntary movements, involuntary shivering, and non-shivering thermogenesis. Your basal metabolism actually accounts for the heat produced in your body at absolute rest. So your basal metabolism is heat produced at absolute rest. Your average basal metabolic rate depends on body surface and your thyroid hormones. Um, and you'll see non-shivering thermogenesis occurring most often in neonates. Heat loss. So you have loss and production occurring together. Radiation is transfer of heat from one surface to another without direct contact. So radiation, transfer of heat from one surface to another, no contact. Conduction is transfer of heat from an object to another with direct contact. So conduction, transfer of heat with contact. Convection is a transfer of heat away by air movement. So fans promoting heat loss. Some of you might have a convection oven. It uses air movement to heat the whole area. And then, of course, evaporation is the transfer of heat energy when liquid is changed into a gas. It continuously occurs. So diaphoresis, or sweating, primarily occurs on your forehead and upper thorax. That's evaporation. You sweat, the sweat evaporates off your skin. Your skin provides you with insulation, vasoconstriction, and temperature sensation. You've got your skin, your subcute, and your fat to help keep heat inside. And the heat transfers from blood through vessel walls to the surface of the skin. So there is some behavioral control. So you are able to control your body temp depending on the degree of temperature extreme, your ability to sense feeling comfortable and uncomfortable, thought processes or emotions, and your mobility and ability to add or remove clothing. For instance, today is supposed to be extremely hot. So that would be the degree of temperature extreme. So you might add or remove clothing, probably removing them. Factors that can affect body temperature. So in children, temperature regulation is very unstable until they get to puberty. The usual temperature range of an adult drops as they get older. Older adults are very sensitive to temperature changes, and any form of exercise increases your metabolism, thereby increasing heat production. Women actually experience a greater flux of temperature than men. And of course, there's hormonal variations. Menopause, you got the hormone variations causing you hot flashes. Body temps normally fluctuate 0.8 to 1.8 degrees Fahrenheit in a 24-hour period. Your temperature is actually one of your most stable rhythms in your human body. Your lowest temp will be between 1 and 4 in the morning, and your max, you'll peak out at about 4 in the afternoon. When you're on a night shift, it takes 1 to 3 weeks to reverse your temperature cycle. So, meaning between 1 and 4 in the afternoon is where you'll be lowest, and at 4 in the morning is when you'll be your highest. Stress, of course, can cause temperature change through hormones and neural stimulation. Alterations in temperature, so fever, or what's also called pyrexia. Heat loss mechanisms are unable to keep pace with the excessive heat production. Not really very harmful if it stays below 102 degrees Fahrenheit or below, or 104 in children. One single temperature reading that's elevated does not indicate a fever. You have to have more than one reading to indicate a fever. A true fever occurs because of an alteration in the set point in the hypothalamus. So febrile, you have a fever, versus afebrile, no fever. And then you have what's called an FUO, not UFO, FUO, fever of unknown origin. You don't know where it comes from. So interesting point I want to bring up with the COVID-19. A lot of you know one of the symptoms is a fever. Well, I'm part of a Facebook group of nurses and providers that are in on the with this COVID-19, specifically COVID-19. And one of the nurse practitioners brought up yesterday that she is noticing a trend in their patients who are recovering and they're almost recovered and ready to go home. Their temperatures actually drop to about 94 to 95. And then they stay there. So there's something when you have these fevers that is causing a reset, maybe of the set point, and is actually dropping the body's set point temperature. It's kind of interesting that something is happening in the hypothalamus. Hypothermia is an elevated body temperature that's related to your body's inability to promote heat loss or reduce production. So your temp goes up, either you can't lose the heat, so your temperature goes up, or you're not, or you're unable to reduce the amount of heat you're producing. It can result from overload of thermoregulatory mechanisms versus a fever, which is the change in the actual set point. Malignant hyperthermia is hereditary. It's uncontrolled heat production that occurs when a susceptible person gets certain anesthetics. So you will only see malignant hyperthermia when certain anesthesias are used. Heat stroke results because of a prolonged exposure to high environmental temps, and that completely overwhelms your heat loss mechanism. With a heat stroke, you're going to see temperatures over 104 degrees Fahrenheit. Heat stroke has high mortality and is a medical emergency. Signs and symptoms of heat stroke: giddiness, confusion, delirium, excessive thirst, nausea, muscle cramping, visual disturbances, and incontinence. So again, signs and symptoms are giddiness, confusion, delirium, excessive thirst, nausea, muscle cramps, vision disturbances, and incontinence. The most important sign of heat stroke is hot, dry skin. Most important sign, hot, dry skin, because you don't sweat due to electrolyte losses and hypothalamic malfunction. In heat stroke, you can have permanent neurological damage. Heat exhaustion occurs when you have profuse diaphoresis or sweating that then leads to excessive water and electrolyte loss, usually caused by environment. So you're going to hit heat exhaustion before you hit heat stroke. And then hypothermia. Heat loss during prolonged exposure to cold overwhelms the body's ability to produce heat. So it's so cold, your body cannot produce enough heat. So there are three classes of hypothermia. There's mild, where your temperature, core body temperature, okay? Core body temp, guys. Mild hypothermia is 93.2 to 96.8 degrees. Moderate hypothermia is 86.0 to 93.2 degrees. These are Fahrenheit, obviously. And then severe hypothermia is anything less than 86 degrees. Rule of thumb, guys, a person's not dead until they're warm and dead. So if they are hypothermic, you need to warm them up before you completely write them off. Hypothermia can develop gradually and go unnoticed for hours. When the temperature goes below that 93.2, you're going to see uncontrolled shivering, loss of memory, depression, and poor judgment. As your body temperature falls, your heart rate, respiratory rate, and blood pressure will decrease, and your skin becomes cyanotic or blue. So frostbite actually occurs when the body temperature, yes. So for mild hypothermia, it's 93.2 to 96.8. Moderate hypothermia is 86.0 to 93.2. And severe hypothermia is less than 86 degrees. When you get to below 93.2, so when you're in the severe to moderate range, you're going to have that uncontrolled shivering, loss of memory, depression, and poor judgment. Again, your temp falls, so does your heart rate, your respiratory rate, and your blood pressure. So basically, all your vital signs start decreasing when your temperature decreases, and your skin may start turning blue. Frostbite happens when the body temp is exposed to subnormal temps. And what happens in frostbite is that ice crystals actually form inside your cells that causes permanent circulatory and tissue damage. So, temperature, where do we assess it? You do oral, it's easily accessible, most comfortable for patient usually, unless they've had mouth surgery. It does give you pretty accurate surface temperature, and it quickly reflects changes in core temp. So if you have a rapid change in core temp, the oral temperature will also change quickly. You have to delay it if the patient has had anything hot or cold, smoked, or receiving oxygen. So if a patient says that I just ate a bowl of soup, you're going to want to wait at least 30 minutes until the temperature is taken. Same thing for cold. Chewing gum also can affect oral temperature. You do not want to take oral temps with patients with oral surgery. Also, not really great for infants, children, or confused patients. The risk is you can, with oral temperatures, have body fluid exposure. Tympanic, again, this is in the ear. Easily accessible, minimum repositioning, can be done without actually disturbing the patient. Doesn't affect the patient's breathing. It is sensitive to core temperature change also. Very rapid. It's unaffected by oral intake, and it can be used in infants. And it reduces the heat loss for infants, so you're not uncovering them to get to their skin. And generally, tympanic temperature is not influenced by the environment. You do have more variability than with other core temp devices. They may have to remove hearing aids. You have to have disposable covers. If they have an ear infection or earwax, that will change the reading. Don't, of course, use in patients who've had ear surgery. Ambient temperature devices like incubators or warmers can cause changes. And you want to make sure you get the correct position. Infants and children have a different position in their ear canal than adults. Rectal temperature is more reliable when the oral temperature is difficult or not possible to obtain, but it does lag behind core temp during rapid changes. Definitely not one you want to use for patients who have diarrhea or rectal issues. It does require positioning. It can cause embarrassment, and you do risk body fluid exposure and injury to the rectum. You also need to have lubricant, and you don't want to use this for routine vital signs for a newborn. Also can be changed by impacted stool. Skin, checking using the skin. Inexpensive, provides continuous reading. It's safe and non-invasive. It can be used in neonates. It does lag behind other sites. The adhesion of the skin thermometer can be affected by sweating. It is also affected by environmental temp and can't be used in patients who have adhesive allergies. You have the temporal arterial. You don't have to change position. It's very rapid, comfortable. You don't have to disrobe or unbundle a child. You can use it in premature infants, newborns, and children. It does reflect a rapid change, so in core temp, and you don't have to use a sensor cover because you can just clean the device. It is inaccurate though if someone has a head covering or hair on their forehead, and also can be affected by skin moisture. Then we also have axillary, very safe and inexpensive. It is reliable and stable in preterm infants. It takes a long time though to get the measurement. You have to position. It lags behind the core temp. It's not recommended for detecting fevers. It requires exposure of the thorax, which results in excessive heat loss. It can be affected by exposure to the environment, including the time it takes to place the thermometer, and it definitely underestimates the core temp. To get a core temp, it requires a continuous invasive device placed in body cavities. So different types of thermometers. You have the electronic, which is rechargeable or has a battery, disposable probe covers. You have two different modes, one that's a 4-second predictive and one that's a 3-minute standard. Readings can appear within seconds, and they're easy, and you could just clean them between patients. The electronic thermometer that we have in that picture there, you see two different probes. One is oral and one is rectal. Please do not confuse the two. There's also the chemical dots. They can be single use or reusable. They're thin strips of plastic with a temperature sensor at one end. They're chemically impregnated with dots that will change color with different temperatures. They have Celsius and Fahrenheit versions. And reading usually, you can get a reading usually within about 60 seconds or so. As you've delegated vital signs to assistive personnel, and the assistant informs you the patient has just finished a hot bowl of soup, your most appropriate advice would be to A, take a rectal temp, B, take the oral temp as planned, C, advise the patient to drink a glass of cold water, or D, wait 30 minutes and take the oral temp. Yes, good job, guys. D, wait 30 minutes and then take the oral temp. All right, so interventions for fever. What kind of things can you do for fever? Well, blood cultures. Blood cultures are the first thing you should do if you suspect an infection. If the doctor orders antibiotics and you suspect an infection, you might want to call him and say, hey, or her, and say, would you like or I start the some places will actually have standing orders that you can do that and you don't have to wait. You also would like to do cultures if a temp spikes, which indicates an increase in antigen producing organisms. You want to minimize heat production, so rest and reduce activity. Maximize loss, so uncover the patient without causing them to shiver. Clean bed linen, keep their clothing dry, their bed linen dry. You want to make sure you're satisfying requirements for increased metabolic rate. So you want to give them oxygen, stimulate their appetite, and provide fluids. You want to promote, of course, comfort in general. And then identify onset and duration of febrile episodes. Is it constant? Is it intermittent? Control the environmental temperature if they have a cooler in the room if you can. Administer antipyretics as ordered. And then watch children ages 6 months to 3 years for febrile seizures. Seizures. Again, monitor any child from 6 months to 3 years for febrile seizures. So, patient that has heat stroke, you want to move them to a cooler environment. Remove any excess clothing. Place cool, wet towels over the skin. Notice it says cool. I said cool, not cold. Cool. Use oscillating fans so they're not directly, but they move back and forth over the skin. In the ER, you might give them IV fluids. You might irrigate the stomach and lower bowel with cool solutions. That would require placement of like an enema or a rectal tube. And also use hypothermia blankets to bring their temperature down. In hypothermia, the priority is to prevent any further decrease in temperature. So remove any wet clothes, replace those with dry ones. Hypothermia, the temperature's dropping, they've got wet clothes, you just took their clothes off. Now their skin is completely exposed. So you want to make sure that you get the wet clothes off, get them dry, and get them covered up again. Make sure you're wrapping them in blankets. If you're away from a healthcare setting, you want to put the patient under a blanket with someone lying next to them. Your body heat or someone else's body heat will help radiate. If they're conscious, have them drink hot liquids. Keep their head covered. Most of their heat loss occurs through your head. Place in a warm room or near a source of heat. You can use heating pads to the head and neck because that's where heat is lost the quickest. Again, if there's an infection, you want to make sure your patient completes their antibiotics and make sure you're encouraging them to continue to take fluids. All right, guys, let's take a short break again, another almost 10-minute break. So come back at noon and we'll get started on the pulse rate. So get up, stretch, use the restroom, get a snack, something to drink. Okay, next, pulses. So a pulse is a palpable bounding of blood flow in a peripheral artery. It's an indirect indicator of circulatory status because of continuous blood flow. The pulse wave created by stroke is created by stroke wave injection, and it moves 15 times faster through the aorta and 100 times faster through small arteries. A change in your heart rate can indicate a change in cardiac output. Most commonly used pulse sites are radial, so in the wrist, what you're seeing there, and then the apical, which is at the point of maximum impact of the heart. You can also use the carotid in an emergency because the body will keep blood flowing to the brain first. Now, to do an apical pulse, you do need a stethoscope. You can't feel it, you have to listen. And you need to make sure the diaphragm or bell is in the correct position. So the diaphragm actually transmits the high-pitched sounds, so your bowel sounds, lung sounds, and heart sounds. Don't use your thumb to hold the diaphragm in place. If you do, you're going to hear your own pulse. And the bell part hears lower pitch sounds, so some of the heart and vascular. So normal rates in an infant, a normal rate is 120 to 160. In a toddler, the normal rate is 90 to 140. Preschool, 80 to 110. School-age child is 75 to 100. Adolescents run 60 to 90, and then the adults 60 to 100. So again, infants 120 to 160, toddlers 90 to 140, preschoolers 80 to 110, school-age child 75 to 100, adolescents 60 to 90, and adults 60 to 100. The apical rate requires you to, again, listen, and you're listening to the first and second heart sounds. It's that lub-dub that you hear. So tachycardia is actually an increase in the heart rate, and bradycardia is a slow rate. You may have what's called a pulse deficit, and that's an inefficient contraction of the heart, and it fails to transmit a pulse wave to the peripheral site. So, and when you're checking for pulse deficit, you have to do radial and apical at the same time, and you'll need 2 people. When we're talking about the rhythm of a pulse, a dysrhythmia is an abnormal rhythm, okay? You actually palpate interruption in successive pulse waves or auscultate that. Now, you can have a pulse that's regularly irregular. So at certain intervals is where it becomes irregular. So every 5 seconds, the pulse becomes irregular. Or it can be irregularly irregular. There's no rhyme or reason. It just all of a sudden becomes irregular, then back to normal, then irregular, and there's no timing or anything to it. Excuse me. You want to use an EKG or heart monitoring to check rhythm. Now, that being said, children have a heartbeat that will speed up when with inspiration, and it slows down with expiration. So when a child inhales, their heart rate speeds up. When they exhale, it slows down. So in order to get a better idea of their rhythm, you may have them hold their breath, so their heart rate becomes more regular. Don't let them hold it too long. Strength, reflects the amount of blood ejected against the arterial walls with every contraction. So you're going to document strength as bounding, which is 4, full or strong, which is 3, normal or expected, which is 2, diminished or barely palpable is 1, and of course, absent pulse is 0. So again, it's going to be bounding, which is 4, full or strong, which is 3, normal or expected is 2, Diminished or barely palpable is 1, and absent is 0. And then the last thing you want to check for equality assess both sides. Are they the same? The only one that's not going to be the same all the time, don't check the carotid at the same time. If you check both carotid pulses at the same time, you're cutting off their circulation to the brain, and you can cause your patient to pass out. So only do equality on everything except the carotid arteries. So you have your pulse sites. You've got the temporal, which is over the bone of the head above and lateral to the eye. Your carotid, which is against the sternocleidomastoid muscle in the neck. Apical, which is at the 4th to 5th intercostal space at the left midclavicular line. Brachial, which is the groove between the biceps and triceps at the antecubital fossa, which is where your elbow is. Radial is the thumb side of the wrist. Ulnar is the finger side. Femoral, it's below the inguinal ligament, midway between symphysis pubis and anterior superior iliac spine. Popliteal is behind the knee in the popliteal fossa. That one can be very, very difficult to feel. Then you have posterior tibial, which is the inner side of the ankle, below the medial malleolus, that bump. And then dorsalis pedis is on the top of the foot between extension tendons of the great and the first toe. So your big toe and your first toe. Most of those you can usually feel. One time when I was working in an ICU, we had a patient brought from the ER. They had put pacer pads on her, and she had gone to CT scan and then came to us. And so the monitor was showing 60 beats a minute. And I'm looking at her and she's looking awfully blue. And, there's a bunch of us, the respiratory person was there because they were ventilating her because she was intubated when they brought her. And then I forget it. I think it was a tech or somebody also brought her over. So the nurses and I are working on getting her into the bed, and we get her on the bed and I'm looking at her and I'm like, so I go to feel a pulse and I try the radial first. Can't feel it. Now I can't get to the carotid because there's a nurse up by her head. So I looked over at the nurse across from me. I'm like, Jerry, I can't feel a pulse. Can you? So we both went femoral, no pulse. I don't know how long that patient had been pulseless because she had the pacer pads and they were firing. It made it look like she had a heartbeat, but there was no beat and she was not perfusing. Immediately we have to call a code. Unfortunately, the patient didn't make it. So make sure if you have a question, you use multiple sites to determine. Yes, Veronica, she had pads on her chest that were shocking to try and get her heart beating. So they were shocking, and the machine, the monitor was reading the shocks as a heartbeat, but her heart itself was not actually beating. The look on the respiratory therapist's face when we told her there was no pulse, but it shows a rhythm. Yeah, it's the pacing rhythm. It wasn't the heart rhythm. So very scary situation. So, okay, you notice the teenager has an irregular pulse. So best action, A, read the history and physical. B, assess the apical pulse rate for 1 full minute. C, auscultate for strength and depth of pulse. Yes, Christina, there was not an RN with the transport. Don't ask me, I don't know. Or D, ask whether the patient feels any palpitations or faintness of breath. So what's your answer? Teenager is an irregular pulse. What's your best action? A, reading the H&P. B, assessing apical pulse for 1 full minute. C, auscultating for strength and depth. Or D, asking if the patient feels anything. So in this instance, you want to check the apical pulse. So say you're using so in this instance, you're palpating at a peripheral pulse, so radial. Next thing you do is verify it with the apical pulse. So anytime you have an abnormal or it's unusual peripherally, you want to then assess the apical pulse. And if you do a pulse for 30 seconds, you definitely want to do one for a minute. Respiration, it's a passive process. Human survival depends on the ability of oxygen to reach your cells and for carbon dioxide to come out of the cells. It's the mechanism that your body uses to exchange gas between the atmosphere and the blood and the cells. So with respiration, you have to have ventilation, which is the movement of gases into and out of the lungs. Diffusion, which is the movement of oxygen and carbon dioxide between the alveoli and red blood cells. And then perfusion, which is distribution of red blood cells to and from pulmonary capillaries. So again, you need to have ventilation, which is the movement of gases into and out of the lungs, so the act of breathing. Diffusion, where oxygen and carbon monoxide move between the alveoli and the red blood cells. And then perfusion, which is distribution of red blood cells to and from the pulmonary capillaries. Now keep in mind, oxygen binds to hemoglobin. That's why the red blood cells. So that's also why pulse oximetry works, is because it's measuring oxygen on the red blood cells. Problem can be is that carbon monoxide also has an affinity to hemoglobin and can cause abnormal readings. Your respiratory center is found in the brainstem, and your body will regulate your ventilation based on your carbon dioxide levels, oxygen levels, and also hydrogen ions in concentration in arterial blood. Most important factor in controlling respirations is your carbon dioxide level, not the oxygen, but carbon dioxide. If you have excess carbon dioxide, that's called hypercarbia, and it is commonly seen in COPD, or chronic obstructive pulmonary disease. So your body removes that excess carbon dioxide by increasing exhalation. Hypoxemia is low levels of arterial oxygen. You do, muscle work is involved in passive breathing. Now, inspiration itself is an active process. The diaphragm contracts, abdominal organs move down, and the ribs retract upward from the midline. With expiration, your diaphragm relaxes, the abdominal organs return to normal position, and the lung and chest wall return to a relaxed position. Expiration is a passive process. So inspiration is active, it requires muscle movement. Expiration is passive, the muscles relax. When you sigh, that's a protective physiologic mechanism to expand the small airways and alveoli that aren't ventilated during a normal breath. Respiratory rates, assessing ventilation, easiest to do. Do not use an estimate, use observation or palpation. You can put your hand on the chest. Don't let the patient know you're assessing their respirations, because they can alter their respirations. So what I do, I take their pulse and then I keep looking, I keep counting, and I watch their chest rise and fall. They think I'm still taking their pulse, but I'm really watching their chest. Factors that can influence ventilation: exercise, acute pain, anxiety, smoking, body position, some medications, neurologic injury, and then also hemoglobin. Capnography measures the exhaled carbon dioxide throughout exhalation. So you're looking at the amount of carbon dioxide that's exhaled. Rate, you want to look at a full inspiration and expiration when counting a rate. So an inspiration and expiration is 1. A respiratory rate of over 27 is important risk factor for cardiac arrest. So if they're breathing faster than 27 breaths a minute, increased risk of cardiac arrest. Depth refers to the degree of movement of the chest wall. And you're going to describe ventilatory movements as deep or shallow and normal or labored. If they're breathing heavily, that's labored. So, alterations you may find: bradypnea, which is a regular rhythm of breathing, but it's slow, so less than 12 respirations a minute. Tachypnea, which is also regular, but it's fast, so it's greater than 20. And then you have hypernia, which is labored breathing with an increase in depth and a rate of over 20. That's what you see with exercise. So that is normal in exercise. And then apnea is a complete absence for several seconds. Persistent cessation of breathing is respiratory arrest. With hyperventilation, the rate and depth is increased, so they're breathing faster and deeper. Hypoventilation, it's slow and shallow. Cheyne-Stokes, the rate and depth are irregular, and you have alternating periods of apnea and hyperventilation. Kussmaul's respirations are deep, regular, and increased rate. And then you may have Biot's respirations, which are abnormally shallow for 2 to 3 breaths, followed by irregular periods of apnea. Oxygen saturation. So we're talking about pulse oximeter. This helps evaluate diffusion and perfusion. It's the percent of hemoglobin that is bound with oxygen in the arteries. Okay. That is called the saturation of hemoglobin, or the SaO2, which is different. So SaO2 is the percent of hemoglobin bound with oxygen in the arteries. Okay. It's usually between 95 to 100% is your SAT. A pulse oximeter is a probe with an LED light connected to a cable. It emits wavelengths that the oxygenated and deoxygenated hemoglobin absorb differently, thereby reflecting them back. The photodetector in the probe detects the amount of oxygen bound to hemoglobin and then calculates the pulse saturation, or SpO2. So your SpO2 is a very reliable estimate of SaO2. So some things here that you might find that are things that interfere with light transmission. So skin color, nail polish, movement. Carbon monoxide artificially elevates SATs by absorbing light similar to oxygen. Yes, Veronica, nail polish. Arterial pulsations, hypothermia at the assessment site. So, it's cold. Peripheral vascular disease, so there's not a lot of volume, edema. Those kinds of things can affect it. So, post-op patient is breathing rapidly. You should immediately call the physician, count the respirations, assess the oxygen saturation, or ask the patient if he feels uncomfortable. All right, so a few of you actually said B and C, but your post-op patient is breathing rapidly. So you probably know what their rate is. So you probably already counted the respirations, but you guys aren't completely wrong. So that's good. But the answer is actually C, assess the oxygen sats. Because shortness of breath is an indicator that there's hypoxemia occurring. And so by assessing the saturation, you will actually know if the breathing is because of hypoxemia, so low oxygen levels in the blood. Good job, you guys. Oh, blood pressure, everybody's favorite. So blood pressure is a force exerted on the walls of an artery by pulsing blood under pressure from the heart. It moves from high pressure to low pressure. So your blood's going to move from the area of high pressure, your heart, to lower pressure, the rest of your body. Your systolic pressure is the peak of maximum pressure when ejection occurs. So when ejection happens, it's the highest amount of pressure. That's systolic. Diastolic is the minimal pressure exerted against arterial walls at all times. So the minimum amount of pressure, the least amount of pressure. Standard unit is the millimeters mercury, or mm capital Hg. The difference between diastolic or systolic and diastolic, in that order, is called a pulse pressure. So your cardiac output, your blood pressure depends on your output. Excuse me. Cardiac output is the volume of blood pumped by the heart in 1 minute. So your normal cardiac output should be about 5,000 milliliters. That's how much blood should be pumped out of your heart in a minute. It can increase, cardiac output could increase due to increased heart rate, increased muscle contractility, heart muscle, or an increase in blood volume. Okay, that makes sense. More volume, increased output. Peripheral resistance is determined, the resistance to blood flow is determined by the tone of your vascular muscles and the diameter of the blood vessels. So the smaller the lumen, or the opening of the vessel, the greater the resistance. If you have increased resistance, that can increase blood pressure. If you have increased blood pressure, that can cause increased resistance. Blood volume is an increase in blood volume increases pressure against the arterial walls, as I mentioned. Viscosity has to do with the thickness of the blood. The hematocrit is a percent of red blood cells in the blood, and that's the number you're going to look at to determine viscosity. Elasticity, normally the walls of the arteries are elastic and easily distensible. When the pressure increases, though, the diameter increases to accommodate that pressure change. If you have decreased elasticity, that increases resistance because they're not opening as much. And that will cause an elevation in your systolic pressure. So increased resistance increases systolic pressure. Factors that can influence your blood pressure: age, there's normal variations throughout your life. You want to look at the child's blood pressure in respect to their body size and age. Stress is a factor. Anxiety, fear, pain, emotional stress will increase blood pressure. Ethnicity, there's a higher incidence of high blood pressure in African Americans. And they also have more severe hypertension at an earlier age. And African Americans are at twice the risk for complications. Gender affects blood pressure. So after puberty, males will be higher. After menopause, women will be higher. There is daily variation like there is with temperature. So it's lower between 12 and 3 a.m. And then between 3 and 6 p.m., 3 a.m. and 6 p.m., there's a slow and steady rise throughout the day. You may have an early morning surge when you wake up. And your highest blood pressure reading will be between 10 in the morning and 6 in the evening. Medications may directly or indirectly affect your blood pressure. Your activity and weight, period of exercise can reduce blood pressure for several hours. And then obesity and weight gain contribute to high blood pressure. Smoking also influences blood pressure. It causes vasoconstriction, so that narrows the lumen of your blood vessels, increasing your pressure. And your blood pressure will actually return to baseline about 15 minutes after you stop smoking, or a patient stops smoking. Here we have some normal blood pressure averages. Newborns, 1 month, 1 year. An adult, again, less than 120 over 180. Hypertension and hypotension, very important. Hypertension is huge. A lot of times hypertension is asymptomatic, although some people may report a headache. Prehypertension can be diagnosed if you have 2 or more readings on at least 2 subsequent visits. So you have to have 2 readings on 2 subsequent visits. So you have 1 reading and it's elevated, the patient comes back and they have a second reading, it's elevated. Prehypertension will be, the systolic will be 120 to 139 and a diastolic of 80 to 89. So again, prehypertension, systolic 120 to 139 and diastolic 80 to 89. It can be associated, hypertension is associated with thickening and loss of elasticity of the arterial walls. Your blood flow decreases. If you have a family history, that increases your risk. And when a patient has a diagnosis, educate them on their normal blood pressure values, long-term care follow-up and therapy, lack of symptoms, ability to control but not cure. The diastolic was 80 to 89. And also educate, you're welcome, educate your patient to follow up with the treatment plan. Now, hypotension is a systolic less than 90. Okay. Causes of hypotension can be dilation of arteries, so they widen up bigger, loss of volume, substantial loss like hemorrhage, or failure of the heart to pump adequately. It can be hypotension. You may see pallor, or they may be pale, or their skin mottles. Yes, Veronica. You'll see here, these are the JNC 9 guidelines. Okay, where was it? Oh, hypotension, clamminess, confusion, an increase in heart rate, or a decrease in urine output, and that is considered life-threatening. Hypotension occurs when a person develops symptoms and a drop in pressure by at least 20 millimeters of mercury, a systolic or a diastolic at least 10 millimeters within 3 minutes of rising. That's orthostatic hypotension. People who are at risk are people who are dehydrated, anyone who's anemic, or have experienced prolonged bed rest or recent blood loss. That would lead to orthostatic or postural hypotension. Some medications can also cause that. So measuring your blood pressure, you have the sphygmomanometer and a stethoscope is what you need, and a cuff. So the sphygmomanometer is the occlusive cuff that encloses an inflatable bladder and a pressure bulb. The size is proportional to the circumference of the limb. The cuff width, so the width of the cuff should be 20% greater than the actual limb diameter, or 40% of the circumference. Or easy way, 2/3 arm length. So the length of their arm, it should be 2/3 of that. You need to make sure you have the right cuff. They need to be calibrated every 6 months. Best environment to get an accurate reading is to make sure the patient's in a quiet room. Same position every time. Your initial assessment, check blood pressure in both arms. There is a normal 5 to 10 millimeter mercury difference. If you have greater than 10 millimeter mercury difference between sides, that indicates a vascular issue. So we have our Karatakov phases. Your phase 1 is your sharp thump. The onset of the sound, so phase 1, is the beginning of your systolic pressure. That's your systolic. The 4th sound that you hear is diastolic in infants and children. In adults, where the sound disappears, it's after the 5th sound. So in children, it'll be the phase 4. In adults, it'll be phase 5. That's where your diastolic is. But that onset of sound is your systolic. So that first sound, regardless of where it is. All children ages 3 through adolescence need blood pressure checks annually. You need to make sure appropriate cuff size. Sometimes it can be difficult to obtain because they're restless or anxious. You want to make sure you don't put the stethoscope too firmly on the antecubital fossa because that can cause an error in auscultation. So Veronica, that might be an issue. I don't know. They do have ultrasonic stethoscopes, so you can hear low frequency systolic. It is an indirect way measurement by palpation is useful when arterial pulsations are too weak to make a sound. So if their arterial pulse is weak, you can use palpation. The oscillatory gap is sounds that you hear over the brachial artery when the cuff pressure is high. It disappears, then it reappears at lower level. That oscillatory gap can cause an underestimation of the systolic or an overestimation of the diastolic. So you hear sounds over the brachial artery, and then it reappears. So that's not your systolic. The systolic is when you first hear any sounds. Inflate the cuff high enough to make sure you hear the true systolic. Palpate the radial artery when you inflate. So when the radial artery stops and you can't feel it anymore, go 30 millimeters mercury over that. And that will get you high enough that you'll be able to hear that first sound. So palpating the radial artery until it obliterates, and then go 30 millimeters of mercury. So if you're at 100 millimeters mercury when the radial pulse disappears, go to 130 and then measure. For lower extremities, auscultate in the popliteal. The cuff needs to be wide and long enough for the thigh. You're going to position the cuff 1 inch above the popliteal artery with the bladder over the posterior aspect of the mid-thigh. So it's going to be in the back, the bladder. Electronic blood pressure machines use electronic sensors to detect vibration caused by a rush of blood. They're easy and efficient, and you don't need a stethoscope, but they are not good when you have irregular heart rates and or unable to process sounds and vibrations of a low blood pressure. Also, if they are not calibrated correctly, they give you inaccurate. Clinic I worked at as a provider, all of our patients were having elevated blood pressures, and we were all using the nurse on a stick. So then we went to using manual, and lo and behold, everybody's blood pressure came down. Even after calibration, the electronic ones were not accurate. Self-monitoring, you want to make sure that their patient's devices, manuals are by far the best. Patients' devices are calibrated frequently. Make sure they're putting the cuff in the right spot and using the right size. It can be beneficial because you can discover blood pressure issues earlier. It can help with adherence with treatment because they see. Some patients will get needlessly alarmed with one elevated reading, and they may adjust the meds without talking to provider. So make sure they're aware that one elevated reading is not an issue, but if they are concerned, to call their provider before making any changes. And then just making sure that education on how to do it correctly is important. I know I'm going over a little bit, guys. We'll make this quick. There's not much left. Some of the cuff sizes here for you. All right, when assessing the blood pressure of a school-aged child, using an adult cuff of normal size will affect the reading and produce a value that is A, accurate, B, indistinct, C, falsely low, or D, falsely high. Right? You would think it would be C. You'd think a bigger cuff would not give you it would be falsely low, but actually the answer is falsely high. So it's D. Really, really weird. But it does. And honestly, if you ask me why, I can't say because I would have said the same thing you guys. But it creates a falsely high reading. And I think it's because of how much you have to blow up the cuff in order to get it around the child's arm. Yeah, I just answered my question and yours, Adriana. Because if you think about it, the arm is a smaller diameter, so you have to keep blowing it up higher and higher and higher and higher and higher. So you're gonna have it blown up to 200, and you're finally gonna be able to hear. So yeah, see, sometimes you just got to talk it out in your head. Or with your students. So as opposed to being falsely low. So, but no, I totally agree with you guys. I would have thought C too. until I just thought it out in my head. Yeah, so Natalie, if you think about it, you're gonna keep blowing that cuff up until it gets tight around the arm. So if it's wrapped too loosely or too big, then you're gonna get a high reading because you're gonna have to keep pumping it up higher and higher. So, recording your vital signs, you want to make sure you record them where appropriate, paper, electronically. If there was anything that you were doing or anything that happened before you checked, like there's a change in status, make sure you document patient had a change in status. So, any precipitating income, um, symptoms or anything. Document any interventions initiated because of those vital signs. Patient's temperature elevated at 100.6. Patient given Tylenol 650 milligrams PO will reassess in 1 hour. Then make sure you go back in an hour and check their temperature. Document if it's outside of anticipated norms, write a variance note explaining that along with your course of action, which we just said. Make sure you address any possible causes of the of fever, for instance. You may say patient has wound infection, temperature 100.6, patient given Tylenol 650 milligrams PO. We'll recheck in 1 hour. And then you go back and check in an hour and he's down to 99.6. So then you're going to document that you rechecked patient's temperature and that it's down to 99.6. Always remember you're doing your date and your time also. And this is kind of a variance note I created on my own. It's not a very good one. So now, guys, I do have a Kahoot for this chapter. It is a little bit longer. And I know I've gone over a few minutes with class. Do you want to go through the Kahoot or do you want me to maybe just post the link to it so you can go over it? Okay. I just wanted to make sure. I really appreciate you guys. Is within reason. Well, I wasn't going to waste it, Veronica. I was going to give you guys the link so you could do it. It's only 13 questions, so it's really, really short anyway. And if anyone has to leave or whatever, feel free. And if you'd like to try this, you have to leave and you'd like to try this, let me know. I can give you the link so you can do it like a challenge. Yeah, no problem, Kristen. All right. Average temperature range. I did Celsius here, guys. Yep. It is 36 to 38 degrees Celsius. So